The point which I want to highlight, don't look in the pelvis for ganglion, which is parasympathetic ganglion. Have you heard of, when you are studying anatomy of the pelvis, that there are parasympathetic ganglion there? There's hypogastric ganglion, but every ganglion is not parasympathetic. Some of them are sympathetic, and hypogastric is sympathetic. Then intramural, the very long preganglionic fibers, very short postganglionic fibers. Is that clear? No question? Okay. And there's no fun in telling that these fibers are concerned with motor to last part of GIT leading to defecation, and to the bladder they will lead to micturition, and for the genital activity in the male, parasympathetic activity will lead to erection, and in female that will lead to vaginal secretions, right? Innervation of urinary bladder. It is an example in which we learn how sympathetic, parasympathetic and somatic nervous system, all of them coordinate, right, to do two functions of the bladder. Number one, that bladder is very much master in filling properly and retaining the urine until you are able to find a proper place, and then bladder can lead to evacuation of urine. Now, how the nervous system coordinate all these things? So, we will draw first of all bladder over here. Let's suppose here is urinary bladder, and in this urinary bladder there is a muscle which is present over here, and this muscle is called detrusor. It is actually smooth muscle, and this is a very special type of smooth muscle. Detrusor is a very special type of smooth muscle in which smooth muscle are connected with each other with very high number of electrical communication systems which are called gap junctions. Again, let me repeat it. Detrusor is a network of smooth muscles which envelop the body of the urinary bladder. It consists of millions of smooth muscle fibers which are interconnected with such junctions through which electrical impulse can pass, jump from one cell to the next cell with low resistance. Due to that reason, whenever detrusor contract, it contracts as a single unit. You cannot say that anterior part of my urinary bladder is contracting and posterior is not contracting, or you can't say that right part of the urinary bladder is contracting and the left is not contracting. Bladder contracts as a unitary system, number one. Number two, a part of the bladder smooth muscle which is present over here, right? This act as a internal urethral sphincter, right? This is internal urethral sphincter, right? And below this, of course, there are some pelvic muscles, you know. For example, if this is a pelvic floor muscle, what could be this muscle? Yes, please. Levator. Yeah, pelvic floor muscles. And then here maybe this is membranous part of urethra which is passing through this area, and there is a very special type of sphincter present over here, and this sphincter, yeah, this is external urethral sphincter. So we can say this is internal urethral sphincter and this is external urethral sphincter. One thing which is a very big difference in the internal urethral sphincter and external urethral sphincter is that internal urethral sphincter is working automatically, involuntarily, and external urethral sphincter is working under voluntary control. External urethral sphincter is working under voluntary control. Now let's draw the spinal cord here and let's talk about the different levels of spinal cord. Let's suppose this is sacral area, suppose as 2, 3, 4, and another segment I represent here, and this is lower lumbar area. Suppose L1, 2, 3, right? And of course, when spinal cord goes upward, right, it will eventually reach, yes, medulla, then into pons, then into midbrain, and then there are higher centers, of course, yeah, cortical areas. Now this represents your central nervous system. Of course, not a very anatomical diagram, but it helps you to understand. Let me tell you, this is sacral area of the spinal cord. Here it is a lumbar area of spinal cord. Then is present thoracic and cervical, and then there is medulla, pons, and higher centers, right? Now we have to see, first of all, let's start with it. You are taking lecture right now, and suppose you have emptied your bladder before the lectures. Of course, when you are taking this lecture and you are sitting over here, kidney is constantly producing urine. Is that right? GFR is, glomerular filtration is going on, tubular reabsorption is going on, tubular secretions is going on. In every minute, about 1 ml urine is produced on average, right? Now what really happens? That urine is passing through the ureters to the urinary bladder, and urinary bladder is right now behaving as a container to store the urine, right? When urine will, let's suppose, reach to the urinary bladder up to the amount of about 50 ml or 60 ml, you may feel initial, some of you may feel initial urge to void, but because lecture is continuing, you can postpone it, right? But as time will pass by, more and more, suppose lecture become very long, more and more urine is appearing into bladder, pressure in the bladder should go up, but actually it does not. Something unusual occur. What is that? That as amount of the urine keep on increasing in the bladder, right, ideally tension in the wall of the bladder should increase, and ideally pressure within the viscus should increase. But something occurs very beneficial, that as urine amount keep on increasing progressively, bladder keep on increasing its size. Due to that reason, in spite of increasing the volume of urine within the bladder, as with increasing volume of the urine, bladder keep on stretching itself, it does not increase the pressure within the bladder significantly, right? Let me draw a graph here, that let's suppose this is the, you are measuring the pressure. Bladder was empty, there was no pressure. Suppose pressure is on this side and volume is on this side. Now what really happens, initially there was no volume. As volume started going up, pressure started, but then as time is going back, time is passing by, volume is progressively increasing, but there is no significant rise in pressure. This part of the curve is called 1A and this is called 1B. Now what is really happening in this part? As time is passing by, volume of urine is increasing, but pressure in the urinary bladder is not increasing. Is that right? Until it reaches about 400 ml, when there will be very strong, you can say around 400 ml, very strong urge to void, right? And then maybe you pressure start going up, and if you really decide to micturate, naturally micturation process, the tussle will contract and pressure will rapidly go up. We call it stage 2. Now we have to study first this phase. Look here, that as urine is coming up, how bladder is able to accommodate more and more increasing volume without increasing the pressure. The principle is Laplace's law. Laplace's law says pressure in a viscous is equal to tension divided by radius. I mean, the tension which is present in the wall, this is the tension, right? And this is the pressure, right? And of course, this is the radius. The maximum radius, if you take the tension of the wall, divide by the radius, that will determine what should be the pressure in the viscous. Now listen carefully. If you keep on increasing the volume here, then naturally tension on the wall will increase. If tension is progressively increasing, and if radius does not increase, then intraviscous pressure should go up. But what really happens? What truly happens is that as volume keep on increasing, there is a little increase in the tension, but with even little increase in the tension, radius of the viscous start increasing. As tension is increasing as well as radius is increasing, so naturally there will not be significant increase in pressure. Is that right? This is Laplace's law. Now, question is that what determines the increase in radiation? One reason is that bladder wall has a very special quality which is called plasticity, biological plasticity. The concept of plasticity is that if a viscous is stretched, the increase in the tension of the wall is not maintained for a long time, right? This is a concept of plasticity. Normally what happens, if you have, it is not elasticity, elasticity is different. In elastic, when you stretch it, there is increase in the tension which is maintained, but in plasticity, initial increase in the tension is not maintained. Now, first we have to talk about the very first thing. When you are taking the lecture, urine is coming into bladder, and bladder is progressively accommodating the more and more volume of urine without any significant increase in the pressure, at least in the initial stages, because it is progressively increasing its size. Now we have to go the very first information that how bladder size increases. One reason I told you the property of the wall of the bladder, that is plasticity. But another reason is neurological connections. Nervous system has some rule that when you are not urinating and you are accumulating the urine, bladder has to keep on increasing its size. Who will explain me how nervous system help the bladder to increase its capacity? Or yes, please. You have no idea. Anyone? Feel free, listen carefully. Let me repeat this question. A person who is sitting in a lecture or in an office, working and not willing to go and pass urine, kidneys are making urine, progressively urine is appearing into bladder. As amount of the urine with the time is increasing, pressure is not allowed to significantly rise in the bladder. One of the simplest mechanism is because bladder also keep on increasing its radius. Which neurological mechanism is responsible for progressively increasing radius of the bladder when you are not urinating, you are retaining, and bladder is in the filling phase? Yes, anyone? Raise your hand. Of course, it's relaxation of smooth muscle, but what is the neurological role? I was about to be impressed. Yes. Anyone? Very good, sympathetic nervous system. You know, it's sympathy with you. You're just sitting in a lecture and your bladder is getting more and more volume of the urine. Do you think you can attend the lecture properly when pressure becomes very high in the bladder? So thank God that sympathetic nervous system sympathizes with you and helps you to increase the capacity of the bladder. Now we have to see that how sympathetic nervous system work. I don't know why students keep on thinking about parasympathetic and bladder, but remember, first you have to fill it and then you have to evacuate it. Parasympathetic help in evacuation, but what helps in filling? That is sympathetic nervous system. That sympathizes with you. Is that right? Now we have to see how it really sympathizes with you. Right? Now, actually, you know, in L1, L2 level or L3 level, you know, there is sympathetic outflow from the lateral horn. All of you know that. Before that, I will tell you there are some sensory, you can say, these are sensations which are taken up from the trigone, and there are sensations which are taken up from the body. Now these sensory systems, they are taking sensation to which part? Through the dorsal root. These are somatic sensations, right? Dorsal root, and from here, okay, these are the sensory pathways, right? Then I will explain how sympathetic nervous system really helps. Again, dorsal root, So first of all, you must know that from the bladder there is sensory output, and this sensory output from the bladder is acting as the input to the central nervous system. Is that right? There are stretch receptors present in the bladder, and especially they are very much concentrated in trigone and urethral part, initial part of urethra, right? They are giving the sensory information here, right? Now let's see how really sympathetic nervous system is activated. But before that, from here, sensory pathways take the sensations, yes, upward. And from here also sensory pathways take the sensations, yes, upward. Now these blue pathways which are taking the sensation upward, they are going to the Pontine centers. There is a Pontine center here related with control of micturition, and in midbrain also there are some centers. Usually midbrain centers are inhibitory for the micturition reflex, and Pontine centers are stimulatory. These sensations are going up. They are consulting and giving the information that bladder is being filled to brainstem centers, and then they are going to the, what is this here? Cerebral cortex. And when this information goes to cerebral cortex, there you, actually this is on the paracentral lobule, medially, not laterally. There these sensations produce the conscious awareness of that your bladder is filling. Is that right? Now, as bladder is being filled, attention please, you are sitting in the lecture. Now listen, traffic of action potential from the sensory system is going towards the central nervous system in the sacral area. Number one, it will activate sacral reflexes, we will see how. Number two, this sensation is taken upward. Now, when it goes to the cortex, cerebral cortex is the seat of consciousness, awareness. You know that you are taking the lecture, you should not urinate right now. So it means that whatever amount of the urine is coming, you should accommodate that. It means there should be activation of some pathway which should lead to increase in the size of the viscus. Is that right? Actually from here descending pathways come. And descending pathways from the higher center which come, they stimulate, what was this? Sympathetic outflow. So they will stimulate, yes please, the dotted line is sympathetic outflow, right? These are sympathetic outflow. Now this sympathetic outflow which is coming from the lateral horn, actually from the descending pathways from here, from the higher centers, right? These pathways which are coming down, they stimulate these sympathetic fibers. Now, as time passes by, sympathetic activity selectively to the, I told you yesterday, usually sympathetic activity is diffuse, but in some examples it is a little bit selective, right? But parasympathetic is usually selective, discrete. Now, the sympathetic activity will progressively increase. Now, what really happens? The sympathetic fibers, number one, they come to, what is this area? Detrusor. The sympathetic fibers will come to detrusor. And number two, some of the sympathetic fibers will go to, yes, internal sphincter. Now listen carefully. What really happens? You are sitting comfortably, but all this thing is happening automatically. That sensory input is going to the central nervous system about the bladder filling. You may become conscious if it is significant stimulation, or you may not be conscious if it is less than significant stimulation. But what really happens, central nervous system decide to hold the urine or still remain in the filling phase of the bladder. For this purpose, sympathetic outflow is increased. When this sympathetic outflow is increased, what really happens, right? That epinephrine, norepinephrine is released at where? In detrusor, and norepinephrine is released at, yes please, what is the sphincter? internal sphincter. Right? Now, when norepinephrine is released here, norepinephrine here and norepinephrine here, it will act on which receptors, please? Yeah, these receptors are beta 2 receptors, and this will also beta 2 receptors. Beta 2 receptors are stimulatory receptors or inhibitory receptors? Inhibitory receptors. So what really happens? The detrusor will relax. So answer was basically, as time passes by, sympathetic activity gradually increases to the bladder and it keeps the detrusor relaxed and increases the degree of relaxation in the detrusor. Right? It's sympathizing with you, isn't it? At the same time, when they are releasing here norepinephrine, the receptor which is present over here, what was this receptor? Alpha 1. And receptor, of course, here is also alpha 1. Alpha 1 receptor is stimulatory or inhibitory? Stimulatory. So it means there will be stimulation to the internal urethral sphincter, and there is inhibition of, yes, there is inhibition of detrusor. So detrusor is inhibited by progressively increasing beta 2 action, and internal sphincter is tightened by progressively increasing alpha 1 action. Due to this reason, thank God, sympathetic system keep on sympathizing with you all the time when you are not passing the urine, and bladder keep on accommodating more and more urine and keep on increasing the size of the viscous. Is that clear? Now, as I told you, as time will pass by, pressure will keep on, volume will keep on increasing. Whenever a volume will increase, sensory input will for a while increase until further relaxation occur and sensory input decrease. It means that basically, attention please, all the sensory input which is going from here, it actually fluctuates. How it fluctuates? Please try to understand it clearly. For example, when initial amount of the urine comes and urine reaches up to a significant amount, volume, right, sensory input will increase. That will increase the sympathetic output and it will relax. When it will relax at a new level, then naturally pressure will go down and sensory sensations will decrease. But after 1 hour or so, again volume will come and sensations will increase. So it means as time will go by, the burst of sensory input will appear again and again, and with the time this burst of sensory input to the central nervous system will increase in intensity and increase in frequency. That will increase in intensity and increase in frequency. Now, when this becomes significantly increased, then we have to talk about another pathway, and this pathway is, yes, there was a lateral horn here. This is anterior horn, right? Now look, now actually from here, from the lateral horn, this is again which lateral horn? Yeah, sacral, isn't it? Sacral, S2 and S3, lateral horn. From here, which fiber will come out? Parasympathetic. From here, the parasympathetic which come out, they have to go to detrusor as well as they have to go to internal sphincter. Parasympathetic have to come out and they have to go to the sphincter, internal sphincter, as well as to the, yes please, detrusor. This is parasympathetic outflow, right? The ganglia for the parasympathetic outflow are present within the urinary bladder wall, transmural, isn't it? Or intramural rather, intramural ganglion. And ganglion for sympathetic, which I did not show, they were hypogastric ganglion, right? Now, these are pelvic nerves with parasympathetic activity. Now, one thing which you have to understand, please, that sensations enter at sacral level and parasympathetic outflow is also at sacral level, but sympathetic outflow is at lumbar level. Of course, it's understandable. Sympathetic outflow cannot be from sacral level. Is that right? Now, what really happens, listen carefully, as I told you that when sensations enter into spinal cord, they give ascending pathways. But actually, there was one thing which I didn't tell you and I must tell, that when sensation enter, they also stimulate, yeah, what is this? Parasympathetic outflow. So what really happens, attention please, that when sensory input goes over there, you try to activate parasympathetic outflow. And if it was so, attention please, if it was so that whenever bladder fill a little bit, sensations go to the spinal cord, from the spinal cord, sensory system directly stimulate the parasympathetic outflow, then naturally urination will occur. Right? But normally it does not happen in adult person with mature urinary system and mature nervous system. Right? He has to decide or she has to decide that socially is it acceptable or not to urinate at a particular time and particular place or not. Right? So it means, listen carefully, that when progressively bladder was being filled, progressively sensations were increasing to the central nervous system, they were stimulating the local parasympathetic outflow as well as they were informing to the higher centers. This was the duty of the higher center, that if higher center decide not to pass the urine, then it is the duty of the higher center initially to progressively increase sympathetic outflow and keep the parasympathetic outflow inhibited. Is that right? It means that as progressively sensations increase to the central nervous system, lower sacral centers should communicate with the higher centers, right? With the Pontine center, with the midbrain center and with the cortical centers. And information which should come down, because higher center know what is the right time and what is the right place and what is the conscious decision to urinate or not. If you are decided not to urinate, then higher center descending pathways will lead to progressively increasing sympathetic activity to the bladder and progressive inhibition of parasympathetic. Is that right? So filling phase will continue and evacuation phase will not start. Am I clear? Now, let's suppose that I have taken a lot of caffeine and I'm keep on giving lecture and lecture become very long. Now really pressure become very high. And if you still decide not to go to the washroom and you want to stay in the class, now the sensations for the voiding or feeling of the desire for the voiding increases progressively. Eventually, central nervous system, higher centers decide it is not enough to just stimulate the sympathetic, because if sympathetic nervous system is fully stimulated, is that right, and it has been fully stretched out and it is significantly inhibited, but there is so much urine now, maybe about 350 ml or around 400 ml, it is really very badly stretching it now, because further relaxation of the blood, further increase in capacity cannot be achieved. This is the time when you really feel very uncomfortable and there is a strong urge to pass urine. If you decide still not to pass urine, then what will happen? Now, listen carefully, then you will consciously hold the urine, and for that purpose, you have to now stimulate external urethral sphincter, right? And you are just praying that lecture should be finished. Is that right? Now, it means another system is activated by the descending pathways, right? For this purpose, what really happens? That, now listen carefully, this is interior horn cells, and which are present where? Again in S2S3. Now, this dotted line was sympathetic outflow, but this is somatic outflow. What is this outflow? Somatic outflow, and this is going out through which nerves? Yes, pudendal nerves. And through the pudendal nerve, these fibers will come and they will stimulate, yes, very bad, not internal. Which one? They will come and stimulate external urinary urethral sphincter. In the same way, these fibers, they will come out and they will stimulate, yes please, external sphincter. Now, this is a situation difficult for females and easy for males because they are longer urethra, but what really happened, they are trying to hold the urine. And this is a very conscious effort. You are standing, he knows how to stand. He is standing in such a way that the sphincter is very tight and maybe pelvic muscles are also very tight. And what is happening, that not only he is trying to have maximum sympathetic activity, and this is the problem now with the higher central nervous system. Higher central nervous system, what it is doing? Number one, they are keeping the maximum outflow of sympathetic, they are keeping the minimum outflow of parasympathetic, and they are keeping now maximum outflow of somatic efferents. Is that right? Am I clear? So the pudendal nerve. Now what really happens? That alhamdulillah lecture is over. If lecture is over, doctors have rushed to the washroom. Now his central nervous system, he has a sigh of relief, bolted from inside, sit on the seat. Now he feels very happy, central nervous system. It's the right place and the right time to void the urine. Micturition should be started. Now we have to see how the micturition cycle will start. Who will explain it to me? Up to now we are holding the urine. You see, I don't know, somehow students always keep on remembering how to pass the urine, but it's more important to hold the urine first. And then, of course, you should know how to pass. Now, we are going to the urine passing stage. Now, central nervous system decide, higher centers, that socially the situation is acceptable, it's the right time, right place, and what really happens? Now, descending pathways come down, in which specially a role is played. Information by the cortical center is given to the Pontine center. That congratulations. What is congratulations? Yeah. That he is in washroom comfortably and there is no line outside. Pontine centers are informed that now you start your activity. These are the true micturition centers. Yes. What I was talking about, now higher centers with paracentral lobules. Now we were talking about that Dr. Rafiq is in washroom. He is very comfortable over there. Now, how he knows he is really comfortable? It is from his cerebral cortex, because all the social matters and cognitive thinking and level of stress and level of comfort, all these are determined by the functions of the cerebral cortex. In this particular case, the role is played by, number one, inferior orbital cortex, which socially decides that are you at the right place and at right time to pass the urine or not. Number two, final decision is made by paracentral lobules. From here the descending pathways come down, and these descending pathways, cortical descending pathways, they will influence the centers in the brainstem. Especially, they will facilitate the Pontine center. When they will stimulate the Pontine center, when these pathways will stimulate Pontine center, these Pontine centers will facilitate the lower center to pass the urine. Now, how these pathways will work? Number one, they will inhibit sympathetic outflow to the urinary bladder. Is that right? Number two, as these pathways are coming down, they will stimulate, parasympathetic outflow. Now, the parasympathetic outflow from S2 and S3, it is being stimulated from the higher descending pathways as well as, please note it, as well as parasympathetic outflow is also stimulated by the local spinal reflex. Now, compare the previous situation and present situation. Previously, when he was holding the urine, what was really happening, that sensory input was going to the central nervous system, and in the sacral area, spinal reflex was trying to activate the parasympathetic. But as socially the situation was not acceptable and he was planning not to void the urine, so when central nervous system at the higher level, cortical level, decided not to pass the urine, then what really happened, that Pontine centers were inhibited, and sacral centers, parasympathetic outflow was also inhibited. But once he is in the right place and he's comfortable to pass the urine, the descending pathway alters its behavior. The descending pathway inhibits the sympathetic outflow, inhibits the sympathetic outflow, stimulates as well. What is this? Pontine stimulation. Again, cortical area stimulates the pontine centers. Pontine micturition center inhibit. What is this? Sympathetic outflow, and stimulate or facilitate parasympathetic and inhibit external urethral system. And it inhibit the nerves, neurons which are going for external urethral sphincter, which is through pudendal nerve. Now, let me go into step by step. All these things do not occur simultaneously. This is called Nucleus of Onuf. This is Nucleus of Onuf. So we can say external urethral sphincter is controlled by sacral nucleus of Onuf. Some say that external urethral sphincter is slave of the Onuf. Now, let's go into step by step. Step number 1. Yes, what is this? Higher centers decided that it is the right place and right time to pass the urine. Higher cortical centers. Right? Number 2. They stimulated, yes, pontine micturition centers. Pontine micturition centers. Next, pontine micturition center will do multiple things. Now, what things it will be doing? Number 1, pontine center, it will be doing multiple things. Number 1, it will relax the muscles of, it will go down, it will come to the somatic outflow, right? It will go to the pontine centers, will come to the somatic outflow, right? And when they come to the somatic outflow, at that very moment, and S2, S3 and S4 outflow, which is somatic, they basically inhibit the somatic outflow. When the somatic outflow is inhibited, it means muscles of pelvic floor and external urethra are relaxed. External sphincter of the urethra is relaxed. So what really happens? Relaxation of muscles of pelvic floor, muscles of pelvic floor and external urethral sphincter. Now, at the same time, it inhibits, yes, what's there? Inhibition of sympathetic outflow from which area? L1, 2, 3. Is that right? Now, after that, what really happens? You know, as soon as pelvic floor muscles will relax and external sphincter will relax, what really happens? Some urine will trickle into most proximal part of urethra. Some urine will trickle into this part of trigone and urethra. Now, this extra urine which has come into this area is extremely rich in sensory nerve endings. So what really happens? That as soon as he relaxes his muscles, a little bit urine trickles into initial part of urethra, and it is very, very rich in sensory nerve endings. There is a very heavy firing of the sensory nervous system. Right? Now, these fibers are going to the central nervous system through 2 routes. Some of these fibers are going along the pudendal nerves, and some of these fibers are going along the sympathetic nerves. Right? It means that sympathetic, now these fibers, sensory fibers, will be strongly stimulated and they will go back and they will have a strong reflex stimulation of parasympathetic. At the same time, higher descending pathways are also facilitating parasympathetic. So we can say there is local reflex local sacral spinal reflex for parasympathetic stimulation, which is now being facilitated by the higher centers. Previously this was being inhibited by the higher centers, now it is being facilitated by the higher centers. Again, previously when he was holding the urine, sympathetic outflow was facilitated. When he was holding the urine, sympathetic outflow was facilitated and parasympathetic outflow was inhibited by the higher center. Now, higher centers have decided to void the urine, so sympathetic centers have been inhibited and parasympathetic centers by the higher descending pathways have been facilitated. At the top, as he consciously relaxes his pelvic floor and little bit urine trickles into initial part of urethra or trigone, there is extra stimulation to this area. The strong sensory input lead to further very strong stimulation of parasympathetic outflow. Then this parasympathetic outflow will be going very powerfully, and naturally when parasympathetic fibers will come to detrusor, they will release acetylcholine there, and that acetylcholine will lead to contraction of detrusor. There are stimulatory receptors over here. At the same time, some fiber will go to internal urethral sphincter, which will relax, because parasympathetic receptors which are present on the detrusor, they are stimulatory, and parasympathetic receptors which are present on the internal sphincter, they are inhibitory. So what really happens that now detrusor is contracting, intravesicular pressure is going progressively high, and what really happening with this, that external sphincter has already relaxed. So urine will be pushed through the urethra and he will start voiding. Is that right? So micturition will start. Again, let me repeat the step. Step number 1, when he has gone to a place where he can pass the urine comfortably, right? What will happen? We have to compare what is happening before that event and what is happening after that. Before he sat on the seat, he was holding the urine. What was happening at that very time? At that very time, before, when he was holding the urine, sensory input was going, right? It was trying to reflexively activate parasympathetic outflow, but parasympathetic outflow was kept inhibited by the higher centers, right? And of course, information was going to the higher centers, and conscious level was determining it is not the time to pass the urine, and higher centers, cortical centers, right? They were inhibiting the Pontine micturition centers, and there was overall stimulation of sympathetic outflow and inhibition of parasympathetic outflow. And if there was strong pressure to pass the urine, but he was not deciding to pass the urine, then of course there will be strong output going through the pudendal nerve for which muscle? External urethral sphincter, to extra effort to hold the urine. But as soon as he sat down on the seat, the central nervous system decided it's the right place and right time to pass the urine. Once this decision has been made, then descending pathways will alter their firing. Now different type of descending pathways will fire. What they will do, number 1, they will stimulate the Pontine centers. From the Pontine centers, further descending pathways will come. They will inhibit the sympathetic outflow. They will inhibit also the outflow, somatic outflow going to the pelvic floor muscles and external urethral sphincter. Due to this reason, little bit urine will trickle into initial part of urethra and pressure in trigone will go up. This area is extremely sensitive to the presence of urine. So a very strong traffic of action potentials will reach to sacral. Now sacral spinal reflex will be activated, right? It will be locally stimulating strongly parasympathetic outflow, and parasympathetic outflow is further facilitated by the descending pathways. Due to that reason, parasympathetic system will stimulate the detrusor, and at the same time there is a relaxation of internal sphincter, and external sphincter is also relaxed. So he will start passing the urine. Once he has completed the voiding, the urethra should be, whatever little amount of urine is present in the urethra, that should be also cleared off. Of course, the last part of urine which was present into this area, that was pushed through detrusor activity. But the last amount of urine which was present in the urethra, how it is expelled? In female, the urethra is short and wide. So it's very simple. In female, it's the gravity which helped to clear off the urethra. But in males, there is a muscle which actively contract and they expel and clear off the urethra. What is the name of that muscle? Yes, please. Who knows the muscle? Yes, Mr. Alim, Mr. Amir, Abed, anyone? In the male, there is a muscle because the urethra is quite long, so it has to be pressed by some muscle so that it can squeeze the last part of the urine. Yeah, bulbo cavernous. That's good. Bulbo cavernous muscle. So there is a little bit, and this is conscious stimulation, right? And that stimulation, you can say, clears off the last drops of urine from the urethra. Is that clear? Dr. Rafiq, are you comfortable? Clear? Now, so this was micturition cycle. After that, what will happen? He will come out of the washroom and next filling stage will start. There is no fun in repeating again. That what will happen? That external sphincter will be tightened and then internal will be also tightened, and with that there will be relaxation of detrusor, and relaxation of detrusor and contraction of internal sphincter will be mediated by progressively increasing sympathetic overflow to this particular area. Any question up to here? Is it clear to everyone? Now we'll talk about the clinical problems related with the bladder or micturition system, right? One of the clinical problem may be that due to some disease, problem is with the sensory input. Problem is with the sensory input bilateral. The classical example is, tabes dorsalis. In tabes dorsalis. Now what really happens in tabes dorsalis, that the dorsal root ganglion and dorsal roots or posterior roots, they undergo fibrotic process, inflammatory process, and then sensory input cannot enter into sacral part of the spinal cord. Now in this particular person, what really happens? That as urine amount is increasing, will this person will be aware of that thing? No. So what really happens? Urine keep on increasing, and bladder keep on distending, right? And eventually bladder become very large due to retained urine and thin walled, right? Right? And eventually, even though the motor system is there, but will it work? No. Because if there is no sensory input going, naturally central nervous system is not aware for the desire for widening. In the same way, sacral reflex, parasympathetic reflex cannot be activated. So this person will retain a large amount of urine, and over the months and years, urinary bladder will become large, overfilled, thin-walled, and eventually overflow, incontinence will occur. This is called de-efferentation. This is called, that efferent pathway has been cut off. De-efferentation. We call this thing de-efferentation. Right? Then another type of problem we can talk about is the denervation of the bladder. Denervation of the bladder means all the sensory and all the motor connections are lost. De-efferentation means only efferent pathway is disturbed. Now we are going to the second patient in which there is denervation. Denervation means this type of problem is usually seen in lesions of the cauda equina or larger lesions, right? And which disturb, you can say, all the innervation going to the sacral area. And you know, in cauda equina actually sympathetic fibers are also coming down, parasympathetic are also coming down, and somatic are also coming down. So all of them are caught into some lesions and they are destroyed. Now what really happens? That there is no sensory input going to the, central nervous system, and there is no motor output coming from the central nervous system. There is no motor output coming from the central nervous system. Under these circumstances, we say it will become an automatic bladder. It will become an automatic bladder, or some people call it, it is simply decentralized bladder because it has lost the connection with the central nervous system. We can say it is de-innervated bladder, or it is automatic bladder, or decentralized bladder. Now in this case, do you think person will be aware of the wish of voiding? No. But what really happens in this person, that urine collect and then bladder automatically evacuate only partially due to myogenic contraction. You know, when you stretch a viscous, then it may contract, right? This type of bladder with the time, because it cannot completely empty itself, right? Every time there is something retained, so pressure remain high. Due to that reason, this bladder become hypertrophied and eventually smaller. So urinary bladder is smaller, denervated urinary bladder is smaller bladder, and hypertrophied bladder, and it may pass the urine out at any moment, but it is not overflow incontinence. It will fill, overfill, then it will partially evacuate, not completely evacuate, then overfill and partially evacuate, but it is not overflow problem. Now again compare. First patient was deafferentation, second is denervation. In the first case only afferent pathway was disturbed like tabes dorsalis, and in second case there was complete denervation of bilaterally, for example large lesions affecting the cauda equina region. In first patient urinary bladder become large, and second patient urinary bladder become small. In first patient we say this is overflow incontinence, in second patient it will become a sort of automatic bladder, right, denervated. Another reason why it becomes small, some people believe that when denervation occur, right, denervation lead to denervation hypersensitivity. When to a tissue, nerve is cut, that tissue under expresses the receptors or over expresses the receptor. When you cut a nerve to a particular tissue, then tissue become deprived of the signals, so it will over express its receptors. So same happens in denervated bladder, that it become oversensitive bladder because different type of cholinergic and adrenergic receptors are over expressed. Then another type of lesion may be in which there is disconnection and lower centers, suppose there is connection, lower lumbar and sacral regions of the spinal cord are disconnected with the upper control, higher control, right? Maybe this spinal cord has been crushed in some accident or due to some tumor, and this crushing of the spinal cord has led to the lesion which does not allow the higher center inhibitory and facilitatory control to the sacral centers. Now it means spinal centers will become independent. It is just like a child. You know, in children, in very early age, do you think they have a control on their urine outflow? No. Is that right? Why? Because higher centers are not myelinated to have inhibitory or facilitatory control on the sacral spinal reflexes. So in these patients, what really happens, they behave like children. Not in other ways, but only about related with the urinary system and maybe with the defecation as well. That these patients, upper motor neuron control is lost on the lower motor neuron control. So lower motor neurons will initially go into shock phase. Shock phase, and shock phase means they will be under firing. The lower motor neurons are initially under firing, then bladder will become loose and flaccid, and pelvic floor muscles will also become loose and flaccid. But as time will pass by, what really happens? That lower motor neuron start overfiring. Over a few weeks, when lower motor neurons start overfiring, then you can say it will become a sort of spastic bladder, and pelvic floor muscles will also become spastic. Is that right? So it will be large bladder or small bladder? It will be also small bladder, and this urinary bladder in which it has lost the control from the upper centers. Number one, patient will not be aware of the urge for voiding. Will the patient be aware of the urge for voiding? Not at all, because information is not going to the, it is cut off here, it is not going to the higher center. This is problem number one. Right? Problem number two is that patient is usually surprised how automatically he passes urine, because he is not aware of bladder is empty or it is full. But because sacral segments of the spinal cord are working well, so sensations go at spinal level, and when enough amount of urine is there, they will stimulate parasympathetic outflow. So it means it is well innervated bladder, but lower bladder controlling centers have lost the influence of the higher bladder controlling centers. So it is sort of, you can say, as we say, this is upper motor neuron type of lesion in the situation. The upper motor neurons are unable to control the lumbar and sacral outflow, which control the bladder behavior. Again, let me repeat it. In this third type of patient, what is there? There is a lower part of spinal cord is working, but lesion is above that, and upper part, higher cortical centers and Pontine center cannot influence the sacral and lumbar centers. Due to this reason, lower motor neurons are released from the activity of upper motor neurons. You know, upper motor neurons are inhibitory as well as facilitatory. Upper motor neuron in this case are inhibitory until patient wants to hold the urine, and facilitatory when patients want to pass the urine. But in this particular patient, because upper motor neurons are no more connected with the lower motor neurons and lower part of the spinal cord, number one, there is no ascending sensation going up sensory system to inform the central nervous system, higher central nervous system about the conscious awareness of the bladder filling. This is problem number one. Number two, bladder automatically fills, and if it has filled to some significant amount, right, it automatically evacuates. Why? Because spinal reflexes are undersensitive or hypersensitive. Hypersensitive, as I told you that when polysynaptic descending pathway, they are cut off. Initially, sacral centers go into shock phase, right? They don't fire, but over the time they start overfiring. So initial phase is underfiring of the lower motor neurons, and then there is overfiring. In shock phase, bladder will become flaccid and urinary retention is there with overflow incontinence, but eventually it becomes automatic bladder and it fills and empties automatically. Is that right? Clinical correlates with autonomic nervous system, right? We'll talk about few syndromes and few conditions. First of all, we'll talk about Megacolon, a condition called Megacolon. This condition is also called Hirschsprung's. Yes, it is called Hirschsprung's disease, H-I-R-S-C-H. Okay, because I don't know spelling is that good, we can write it like this. Hirschsprung disease. Is that right? So this is Hirschsprung's disease. In Hirschsprung's disease, what really happens, the problem is with the migration of neural crest cell. Normally, you know, in the colon, let's suppose I draw the colon here. This is ileocecal junction. Here it is cecum, ascending colon, transverse colon, descending colon. Yes, what is it? Sigmoid, rectum, and then last part of anal. Here is the anal canal. You see that within the wall of the GIT there are autonomic ganglion, you know, enteric nervous system or autonomic ganglion, and the supply of autonomic neurons that is present up to this part, we say it is mainly due to, yes, vagus, and distal part of autonomic parasympathetic supply that is coming from, just please, pelvic nerves. Now what really happens, you know how these ganglions are made. These ganglions are cell bodies which are present within the wall of the GIT, you know, in mesenteric plexus and in mucinous plexus. Now actually all these ganglia are derivative of migrated neural crest cells. These are derivative of migrated neural crest cells. In some unfortunate babies, what really happens, that migration of neural crest cell, especially in last part of the GIT, is impaired. And due to that reason, last part of GIT may develop some segments which are aganglionic. Ganglia are missing there. Extent of aganglionic segment may vary from patient to patient. Again, let me tell you what's wrong with the patient. That there is faulty migration of the neural crest cells. Due to that reason, the layer of autonomic ganglia within the GIT wall is not complete and there is a gap. And we see there is a ganglionic segment. Now, under these circumstances, usually this type of problem is more commonly seen in newborn children, right? If it is a severe problem, it will be diagnosed earlier, but if it is a relatively milder problem, it may be diagnosed later, right? What really happens in these babies that the part of the GIT which is loaded with the ganglion, it means it is working well, so it will keep on propelling the content of the GIT forward. But once the content of the GIT reach to the area where there is, yes, aganglionic segment, a peristalsis cannot move forward. So, contents of the GIT are pathologically accumulated proximal to the aganglionic segment and GIT become pathologically distended. GIT become pathologically distended just proximal to the aganglionic segment, right? There is pathological distension of the GIT. Due to that reason, we call there is a megacolon, large colon, and opposite to that, the area which is aganglionic, because this is adynamic as well, that is underfilled or overfilled? Underfilled, right? This area may be in the descending colon or it may be in the sigmoid colon, but most often it is present in rectum, right? And this condition is called megacolon or Hirschsprung's disease, right? After this, we come to another condition which is called another autonomic disturbance, which is called familial dysautonomia. Of course, you will study this disease in detail in surgery. We are going to the condition called familial dysautonomia. Familial dysautonomia, right? This is an inherited disorder. Usually it is autosomal recessive. When we say this is an autosomal recessive disorder, it means that defective gene should come from the both parents to produce a trouble to the baby. Is that right? Because when we say a condition is related with autosomal recessive situation, it means defective gene is present on the autosome, not on the sex chromosome. And when we say it is recessive gene, it means if one copy is defective, it will not produce abnormal phenotype. So, for autosomal recessive disease, we have to get the, yes, we have to get the defective copies from both parents, or from one parent we should develop defective copy and from other parent gamete should develop a new mutations. But the important thing in case of autosomal recessive disorders is that in autosomal recessive disorders, the defective gene or mutant gene should be present on both homologous chromosome at the same locus, right? You know, there is one chromosome maternal and another is paternal, right? Now, so it means that such type of problems which are autosomal recessive disorders, they will result more often in close marriages. We call it consanguineous marriages. What are your concept of close marriage? If it is in a closed room marriage, this is a closed marriage. What is your concept of closed marriage? Okay, yeah, that's good. Number one, in some families there is a tendency to marry the, you can say, cousins with each other, right? And that is one example of closed marriage. This is one example, yes, that is right. Some people don't marry outside their families, or at least that is what they intend to do so. Then there are, you know, there are some, as I say, there are some familial families which are isolates, that particular families only marry within each other. Then there are religious isolates. Some Jews, they only marry with each other. Then there are geographical isolates. For example, in valley of Kailash in Pakistan, right? These people are geographically isolated and they keep on marrying with each other. So if they develop a defect in one, for example, there is a lady 2000 years back and she developed autosomal recessive defect in her ovum. She may pass that defect half of her babies. Then those babies may pass the defects in their children, then if the children marry with each other, it is quite possible that defective gene come from the both sides, and grandchildren or great grandchildren may suffer with the autosomal recessive disease. So usually autosomal recessive diseases are more common in those situations when there are close marriages, and close marriages mean, rather in Western world they don't call it close marriages, they call it closed crossing, cross mating, right? Because many times they don't go in the true term of the marriage anyway. So what I'm talking about, that in close marriages or close cross mating, we mean not only that family members which marry to each other or try to cross mate with each other, as she is saying, first cousins, but there may be religious isolates and there may be geographic isolates, right? In this particular disease, it's more often seen in the patients coming from the Jew families, right? You know, Jews also, especially Ashkenazi Jews and some other Jews, special type of Jews, they love to marry with each other only, right? Some defects which are present in their line of inheritance due to cross marriages within the same closed loop of the people, the chances of autosomal recessive diseases is very, very high. Now, what really happens in familial dysautonomia, basically there is progressive neuronal loss in autonomic and sensory ganglion. There is progressive neuronal loss or degeneration in autonomic and sensory ganglion. Due to that reason, there may be abnormal sweating patterns, there may be undue fluctuations in blood pressure, or if GIT is not innervated well, as I told you that if GIT ganglia are also degenerating, there will be hypotonia and baby cannot feed well, right? And with that, of course, baby may develop progressive sensory loss. The next condition which we are going to talk about is Raynaud's disease. Again, I am not going to detail of these conditions, we will discuss such things in big detail when we will study pathology. Raynaud's disease, just few words about it. Now, you must know what is Raynaud's disease, and you must know how it is differing from Raynaud's phenomenon. Is that right? So, first of all, what really happens in patient in Raynaud's disease? In Raynaud's disease, basically vasculature of the limb, distal part of the limb, is oversensitive to the sympathetic drive or to the cold or to the emotion. Again, let me repeat it. What happens in Raynaud's disease, right? That vasculature in the distal part of the limbs is oversensitive to the cold. You know, normally in cold vessels should constrict, but if they overconstrict, then we will consider it as Raynaud's disease, right? Or phenomenon. I will tell you what is the difference, right? Or, you know, when you are angry or you are emotional, again sympathetic overflow may occur, and vessels to the cutaneous vessels to the limbs may constrict. But if they too much constrict pathologically, again this is considered Raynaud's disease. So in Raynaud's disease, what really happened, that vessels in the distal part of the limb, especially upper limb, but maybe lower limb as well, in some cases they undergo, you can say, over constriction or spasticity, right, on emotional fluctuations or temperature fluctuations, especially in cold, or some other vasoconstrictor cues. Now, if vessels constrict too much, what will happen? Yes, limb will become, or fingers, or you can say hand will become pale. Doesn't it? If vessels constrict too much, it will become pale. And because blood flow has almost stopped, so whatever blood is present over there and whatever RBCs with hemoglobin are present over there, their oxygen is too much extracted. And a concentration of deoxyhemoglobin become very high. Here I would like to ask a question with someone who is too bright. For example, I am a normal person with normal hand, not Raynaud's disease. Right now, arterial blood is going to my arm and venous blood is coming back. Is that right? If I say hemoglobin is 100% saturated with oxygen in the arterial blood, right? Hemoglobin is 100% saturated in, yes, arterial blood. When venous blood is going back, what is the saturation of hemoglobin? Just raise your hands. Okay, question goes to some smart young man, Dr. Naeem. My question is so simple that blood is going to the limbs, is that right? And arterial blood which is approaching the limb is 100% saturated, he is about to weep, right? And 100% saturated, and right now the blood which is coming back, and if you measure the concentration of oxygen in arterial blood and concentration of oxygen in the venous blood, hemoglobin is 100% loaded. On the way back, what is the percentage of hemoglobin which is deloaded? Yes, yes. One by one, I will come to you definitely. I am sure I will reach up to that. My question is so simple that because a very basic question, everyone should know that in a normal person, physiological conditions, arterial blood is carrying 100% oxygen if it is lungs are working well, is that right? Oxygenation pattern and hemoglobin is normal, is that right? Blood is almost 100% saturated, right? Let me tell you that if there is 100 ml blood, okay, let me give you some clues. Let's suppose in arterial blood, of course this is brachial artery, isn't it, not femoral. In this brachial artery, suppose 100 ml blood is there. In 100 ml blood, let's suppose 15 gram is the hemoglobin. Usually, if hemoglobin is 100% saturated, usually 1 gram of hemoglobin take 1.3 ml of oxygen. 1 gram of hemoglobin, if it is fully saturated, will capture how much oxygen? 1.3 ml. If I say there is how much hemoglobin? 15 gram. So 15 gram hemoglobin can load itself with how much oxygen? 15 into 1.3. It is about 19 to 20 ml. So this is oxygen which is fully loading the hemoglobin. Is that right? This is oxygen which is fully loading hemoglobin. With that, there is a small amount of oxygen which is dissolved into plasma. That is about 0.3 ml. So approximately in 100 ml of blood, write it down, in 100 ml of arterial blood with 15 gram of hemoglobin which is fully saturated will have about 20 ml of oxygen. Is that right? Now we have learned one thing, that arterial blood which is passing from a brachial artery to the limb, if you remove 100 ml of arterial blood, how much oxygen should be present there? About 20 ml, because 19.8 ml or so is with the hemoglobin and some is dissolved into now. So we can say every 100 ml of the blood coming to the limb is bringing how much oxygen? 20 ml. Okay, thank you very much for knowing it. Now, next concept is that this blood will pass through capillaries and it will turn back. Is that right? When this blood is going back, before turning back, oxygen is deloaded into tissues, because tissues are, you know, metabolically working using the oxygen and releasing carbon dioxide. So naturally, as compared to arterial blood, when you compare blood gases in the venous blood is relatively poor in oxygen and rich in carbon dioxide. Now my question is, listen very carefully. My question is, oxygen concentration, amount of oxygen, 100 ml blood was carrying how much? 20 ml. When 100 ml venous blood is going back, when 100 ml venous blood is going back, I'm not exercising much. When 100 ml venous blood is going back, how much oxygen will be left behind? Questions start from here. Yes? She says 15 ml will be going back. I mean, Dr. Aisha Khidr is saying that 20 ml is coming here, and by her statement it means that only 5 ml is delivered oxygen and 15 ml is going back. You know, there are people behind it laughing. Yes? What do you think? If 20 ml oxygen come, normal circumstances, how much will go back? Do you have any idea? You are not bothered about physiology, yes? 15 or 16 ml? Yes? 5 ml, yes? 17.1 ml, you are too good in mathematics, yes? How you know this? Because she usually says right thing. 3 ml, sympathetic situation of the limb. 70%. 16 ml. Okay, this you can say word of mouth which I spread is right. Actually, we say that in a resting tissue, other than heart, the resting tissue, when oxygen is passing by, only 25% of the oxygen is extracted. So you are right, it is 15 to 16 ml, she was right. Is that clear to everyone? But when you will start exercising, then extra deloading of oxygen will occur. So it means that if blood, when it was going to the limb, it was 100% saturated with oxygen. When it's turning back, it is about 75% saturated. So if 100% is equivalent to 20 ml, then of course 75% is equal to about 15-16 ml. Is that right? So I'm very happy most of you were right. Clear? Now imagine, in Raynaud disease, vessels undergo spasticity. When vessels undergo spasticity, it means blood flow becomes fast or slow? It becomes slow. Is that right? If blood flow becomes slow, so whatever oxygen is present in this hemoglobin, because more blood is not coming, and whatever blood is present in this hand, that is stagnant, so tissues will try to extract maximum amount of oxygen. So normally what happened, normally first compare normal. Normal what was happening, that oxyhemoglobin was 100%, and out of 100 unit of oxyhemoglobin, 25 was converted into deoxy, and remaining was going back as oxyhemoglobin normally. But when it becomes spastic, blood flow becomes slow, and oxygen is, you can say, RBCs with hemoglobin are stuck over here, local tissue will extract extra amount of oxygen. So it is quite possible that 100 ml blood which is stuck here, 100 ml blood which is stuck here, which was normally supposed to extract oxygen from 5 ml of amount of oxygen, which was normally supposed to extract 5 ml of oxygen, which was normally supposed to you can say deload the oxygen from 1/4 of the hemoglobin. If hemoglobin was 15, then about less than 4 gram was deoxy. But when this disease strikes, blood will go into stagnant phase. Then do you think just 25% of the hemoglobin will lose oxygen, or more hemoglobin will lose oxygen? More hemoglobin will lose oxygen. So percentage of deoxyhemoglobin will be less here or more here? More. And when percentage of deoxyhemoglobin become more than 5 gram per 100 ml, cyanotic look develops. So what really happens, first the distal part of the limbs will become pale, then they will become cyanotic. Cyanotic means bluish tinge will come over there, and cold of course. Is that right? How do you define cyanosis? Cyanosis is a condition in which tissue develop bluish tinge due to, yes, due to presence of deoxyhemoglobin which is more than 5 gram per 100 ml. Now a very simple question, cyanosis, Raynaud's disease, attention please. We were talking about Raynaud's disease, and in Raynaud's disease what I was saying, that basically there is a vasospastic condition of the distal part of the limbs vessels, especially arterial system of distal part of the limb. In response to cold or emotions, right, they have a tendency to undergo undue excessive vasoconstriction. That may lead to severe, you can say, ischemia to distal part of the limb. Initially distal part of the limb may become pale, right, and eventually when blood flow becomes stagnant and whatever hemoglobin is present over there, its oxygen is too much extracted by the tissues, and concentration of oxyhemoglobin become very high, then after some time the limbs will become cyanotic. But when most of the oxygen has been extracted out of hemoglobin and more blood is not coming, or it's very sluggishly coming, then what really happens, tissue develops hypoxia and it switches itself to anaerobic glycolysis, and it does not break down the glucose completely. So glucose is broken down up to pyruvic acid and then into lactic acid, and not to the citric acid cycle where a lot of oxygen is required. So result is that lactic acid and other vasodilator substances are produced by the affected part of the limbs, and then when these vasodilator substances accumulate into high concentration, they produce reactive vasodilation, and when there is reactive vasodilation, that will end up into what thing? The tissue will become hyperemic and red color, right? But of course before that it will develop intense pain as well. Now this condition is called Raynaud's disease if it is not associated with any underlying independent pathology. But sometimes this type of phenomenon is associated with some other disease like scleroderma, right? When this type of phenomenon is associated with some other well-defined disease, or such type of phenomenon is secondary to well-defined disease, then we don't call it Raynaud's disease, then we call it Raynaud's phenomenon. So what is the difference between Raynaud disease and Raynaud phenomenon? That in both conditions there is excessive you can say vasoconstricting tendency in the distal part of the limb to the cold or the emotional fluctuation, but in case of Raynaud's disease, the condition is not associated with any well-defined secondary disease. But in case of Raynaud's phenomenon, what really happens, this particular condition is associated with some underlying condition. Right? Then we come to another situation, just very few words, not detail will be in patho, relationship of autonomic nervous system and peptic ulcer. In some patients of peptic ulcer, you know, peptic ulcer may occur either due to excessive, yes, what is there? Either there is excessive production of aggressive forces like HCl, or there are weakened defenses in the GIT mucosal system. Is that right? In some patients, actually vagi are hyperfunctioning. Not all patients of peptic ulcer, but in some patients of peptic ulcer, vagi are hyperfunctioning, or response of parietal cell to vagal stimulation is excessive, or response of the parietal cell to the vagal stimulation is excessive. That translates into production of excessive HCl. When it translates into production of excessive HCl, then what really happens? That excessive HCl produced chronically may damage the mucosa of the GIT, and a patient may end up with the peptic ulcers. Then one more condition which I would like to talk about is botulism. 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 This is a toxin which is produced by a bacteria. This is a syndrome which is produced by a toxin produced by a bacteria. What is the name of the bacteria? Clostridium botulinum. Clostridium botulinum. In this particular bacteria, this usually develops in, it produces, multiplies and produces toxin in anaerobic environment. For example, if there is honey bottle which is very tightly packed in anaerobic circumstances, or the bean bottle, you know, or anything which is food which is tightly packed and having this bacteria, and food is stored in stored food as an anaerobic circumstances, bacteria will proliferate into that. Yes, what is that? In that medium, and these bacteria will produce an exotoxin which is called botulinum toxin, right? So in anaerobic environment, right, what really happens, Clostridium botulinum multiply in anaerobic environment and produces lot of botulinum toxin. Now this toxin may produce multiple problems. All of you know that when this toxin is present excessively in body, it may produce impairment in neuromuscular junction transmission, right, and flaccidity. With that, it may also actually, basically this toxin affects the cholinergic nerve endings, and cholinergic nerve endings are not able to release what? Acetylcholine. So who will tell me the exact mechanism how this toxin reduces the release of acetylcholine? Yes, do you have any exact mechanism how this toxin reduces the release of acetylcholine? Yes. Do you think she is right? Slightly different. She is humble to you actually. That's a big difference. Yes, what is the right answer?
It doesn't allow the vesicles to fuse.
That's it. Let me tell you what she is saying. Look, let's suppose this is your spinal cord, and here it is alpha motor neuron, right? Alpha motor neuron has a neuromuscular junction here, and of course you know there is a muscle here where it is. Now, first you understand the normal thing. What really happens? Acetylcholine stored into these vesicles, right? When action potential come down, there is a lot of sodium influx, isn't it? Then depolarization of this nerve endings opens the calcium channels, the calcium come in. Now, what really happens when action potential comes, right? There is a sodium influx in the nerve terminal. Sodium influx depolarizes the nerve terminal, and depolarized nerve terminal opens up which channels? Calcium channels. Then what really happens that there is a very special type of, you can say, proteins here which are called, yes, this protein is called syntaxins, and the corresponding proteins here which can fuse with this, and these are called synaptobrevin, right? And there are similar proteins also there. So vesicles are loaded with synaptobrevins, and neuronal membrane is loaded with synaptotegmen. Now what really happens that synaptobrevin and syntaxin, they fuse with each other. Now but when they will fuse, listen carefully. Actually normally these ends of syntaxins are like this, and if this is closed, syntaxin is closed, can synaptobrevin interact here? No. Main function of incoming calcium is, look here, that calcium will bind at this point and at this point, and both points will repel each other, and when they will repel each other, what really happens? They will open up. So in the presence of calcium, we can say syntaxins convert into active form, right? Now what really happens, that vesicle with its which member, what is this thing? Synaptobrevin. Now vesicle with synaptobrevin can interact with this protein. When this protein interact with each other, the membrane of vesicle is fused with the membrane of nerve ending. So what is the basic function? Look here please, that what is this? This is your vesicle. On the vesicle there are synaptobrevins. This is membrane of the nerve ending, and it is loaded with syntaxins. Normally for fusion of both of them, synaptobrevin and syntaxins should fuse, so that this membrane of the vesicle and membrane of the nerve ending should fuse, and then they will produce a hole and acetylcholine will pour out. Is that right? But when there is no calcium, then what was this? Syntaxin, it is off. As soon as action potential comes, sodium comes in, followed by influx of calcium. Calcium opens the mouth of syntaxins. Then from the vesicular proteins which are which one? Synaptobrevin. They interact with the syntaxin and synaptobrevins and other proteins which are nerve ending membrane and vesicular membrane. They interact with each other in the presence of the calcium and help both membranes to fuse. Both membranes fuse with each other. What really happens? Acetylcholine will be released. This is how most of the cholinergic neurons, either they are sympathetic preganglionic or parasympathetic preganglionic and postganglionic, and cholinergic neurons at neuromuscular junctions, they release their content. Now what really happens, the botulinum toxin actually loves to concentrate. This is the botulinum, this is a bottle, okay, right? There's a toxin in it. Botulinum toxin love to concentrate where? Cholinergic nerve ending. Because in cholinergic nerve ending there are special type of proteins which concentrate choline, and this toxin also enters through the choline pathway, right? So what really happens that if botulinum toxins enters into your body, it will love to concentrate into cholinergic nerve ending. Once this toxin goes in, what this toxin is doing? Look here, basically this toxin digests away. This toxin is a proteolytic enzyme. Botulinum toxin is a proteolytic enzyme. It will do proteolysis of these proteins, especially synaptobrevins. So when vesicular membrane proteins are catabolized, is that right? Can vesicle fuse with the nerve ending? No. And if vesicles cannot fuse with the nerve ending, can they pour out acetylcholine? No. And that will end up into what? Failure of cholinergic transmission. Failure of cholinergic transmission, failure of autonomic nervous system, as well as failure of neuromuscular junction system. Is that right? But remember, in these patients, autonomic failures and neuromuscular junction failure is associated with absolutely normal sensory system. There is no defect and problem with the sensory system. It's a pure, you can say, visceromotor and somatic motor outflow failure. But there is no problem with the, yes, sensory system. So this is something about the botulinum toxin. If you want to know, I will tell you a few more toxins which work over here. Very frequently those questions come in USMLE, they are heavy hitters. Number one is, you should know, what was the toxin which was coming here and destroying these proteins? Botulinum toxin. Another toxin which come here, but that does not destroy, rather that helps them to hyperfuse. And there is acetylcholine under released or over released? Over released. First toxin was botulinum toxin, which enter into nerve ending and digest away these proteins and don't allow these proteins to interact with each other. That will translate into failure of cholinergic transmission. But there is another toxin, once it enters into this cell, that will help the both ends to fuse more effectively. Okay, let me tell you, when the other toxin which comes over here, that is like this. And what this is doing? This is helping this end and this end to fuse with each other. What is the name of this toxin? Of course, in this case, there will be very heavy cholinergic outflow and cholinergic crisis will come. Is that right? So all sympathetic activity will become too much. Also, there will be salivation, there will be lacrimation, there will be sweating, there will be defecation and micturition and many other activities like that. So someone who is too good, Mr. Alim. What is the name of this toxin? Okay, I will draw this toxin so that you can really see it. Alam, can you recognize it? It is not tetanus, of course. Tetanus work over here. Is that right? Somewhere here. There are some cells, inhibitory cells present over here, and these inhibitory cells are acted upon by tetanus. We are not talking about that. We are talking about in this area. Yes, please. Yes, please. Anyone from the second row? Feel free to answer. Someone with good neuroanatomy. Anyone from third row? Feel free to answer. Okay, yes, please. Excellent. She remembers things like that. Black widow, look at it. This is a black widow. This is a toxin by the black widow spider. Black widow does not mean that black widow. It means this is a special type of spider. Is that right? Black widow spider which produces a toxin. What is the name of the toxin, by the way? Letratotoxin. Excellent. So this is letratotoxin which is released by spider, and if the spider really injects its venom into you, this will enter into it, this venom will concentrate into your cholinergic nerve ending, and it will help the hyperfusion of, yes, vesicular membrane with the neuronal membrane, nerve endings. So now we have learned two things. There are two toxins which work on the cholinergic nerve endings. There are two toxins which work on the cholinergic nerve ending. One lead to hypofusion, other lead to hyperfusion. Hypofusion, which one? Botulinum toxin. And hyperfusion? Black widow? Spider toxin. Both of them concentrate into cholinergic nerve endings because both of them are bound with the, which one? Both of them bind with the choline uptake system which is present on the, is that right? Now, I think now, right now we can also discuss the role of, someone was confusing this situation with the tetanus. So, let's compare the tetanus pathway. In tetanus, what really happens? Gee, Dr. Saab, you have any idea? In tetanus patient, what really happens? Tetanus toxin. Yes, please. You heard of it? Anything? Very good. When you have tetanus bacteria, Clostridium tetani present over here, and if it there is an anaerobic environment here, it will produce tetanus toxin, tetanospasmin, and this toxin may be taken up through the circulation to the central nervous system, or it may bind with the axons and it travels through the nerve sensory system retrogradely, and then tetanus toxin may reach to the spinal cord segment either through the circulation or through the retrograde travel through the, what is this, sensory system. Once it reaches into spinal cord segment, what will it do? It will inhibit the Rancha cell. How come? Okay, let me let me tell you the very basic thing. To understand how the tetanus toxin work, you should have few basic concepts first of all. Concept number 1. Lower motor neuron have a normal tendency to overfire. Normally, physiologically, lower motor neurons have a high tendency to overfire. And normally they are kept inhibited by inhibitory interneurons. And normally lower motor neurons are kept inhibited by inhibitory interneurons. These inhibitory interneurons are also called Renshaw cells. They are called Renshaw cells. R-E-N-S-H-A-W. Renshaw cells. So in the spinal cord there are Renshaw cells, and Renshaw cells we also call them Golgi bottle 2 cells, or we also call them, just please, inhibitory interneurons. These inhibitory interneurons or Renshaw cells, let's suppose, look here, now I am going to draw the alpha motor neuron here. This is alpha motor neuron, and it has a tendency to overfire. This is nerve ending of the alpha motor neuron. But alpha motor neuron is under the inhibitory effect of which cell? Renshaw cell, right? And Renshaw cell has vesicles, and these vesicles are loaded with glycine. Glycinergic usually. They have inhibitory neurotransmitters. 2 inhibitory neurotransmitters at least you must know. One is GABA and other is glycine. Usually Renshaw cells are glycinergic neurons. Is that right? Renshaw cells are glycinergic neuron. Glycine is an amino acid, I think. Am I right? Okay, thank you for knowing it. So glycine is there into which? Renshaw cells, and normally again there is synapto. What is this? Synaptobravin, and what is it here? Syntaxins. So like other vesicles, here also the vesicular proteins, they are nerve ending proteins. They have to fuse with each other so that they can release glycine, and when glycine will come out, this will lead to inhibition of alpha motor neurons. Any question up to here? There is no question. Now what really happens? That actually Renshaw cells love to concentrate what? Which toxin? Tetanospasmin. So tetanospasmin or tetanus toxin enters into, not tetanus toxide, it is tetanus toxin. Tetanus toxin concentrates itself into the nerve endings of Renshaw cells, and there they work exactly the way botulinum toxin work. You know, botulinum toxin was leading to proteolysis of fusion proteins. Tetanospasmin also lead to proteolysis of these proteins, and if these proteins are undergoing digestion, do you think vesicles now can fuse with the nerve ending? No. So in the spinal cord there will be impaired release of neurotransmitter by glycinergic neurons. So glycinergic neurons fail. When glycinergic transmission fail, it means that Renshaw cells are unable to keep the alpha motor neurons inhibited. Again, let me repeat it. What really happens? A very good doctor must know the comparison between the two things. Number 1 is botulinum, and other is tetanus. In botulinum, there is a toxin involved. In tetanus, there is a toxin. Here the organism in botulinum was which one? Clostridium botulinum. Here the organism was which one? Clostridium tetani. Is that right? Both these bacilli release exotoxins. Now botulinum toxin concentrated into cholinergic nerve endings and outside the central nervous system, and tetanus toxin concentrated into glycinergic nerve ending within the central nervous system. Is that right? This is both. But when cholinergic nerve ending is loaded with the botulinum toxin will lead to proteolysis of synaptobravins and other allied proteins. In the same way, when tetanus toxin concentrated into nerve endings, this also lead to what? Renshaw proteolysis of the fusion proteins synaptobravin. Result is what? The botulinum toxin does not allow the acetylcholine to be released by cholinergic nerve endings, and tetanospasmin and tetanus related toxins do not allow the release of glycine from the Renshaw cells. Now listen carefully. If patient is attacked by botulinum toxin, the neuromuscular transmission will fail and he will develop flaccidity. Opposite to that, there is another patient who got the unfortunately high concentration of tetanus toxin, so it will lead to failure of Renshaw cells or inhibitory neurons within the spinal cord. So what will happen? Alpha motor neurons will underfire or overfire? Overfire. And when alpha motor neurons will overfire, person will develop flaccidity or spasticity? Person will develop spasticity. So this is a comparison between botulinum and tetanus. Again, very rapidly. In botulinum, what was the organism? Clostridium botulinum. And in tetanus, which was the organism? Clostridium tetani. In botulinum, usually bacteria grow into anaerobic food preparations. Here, tetanus bacteria usually grow into anaerobic wounds or within our body. Now, the toxin here on botulinum was botulinum toxin. There, the toxin was tetanus toxin. Botulinum toxin binds with which kind of, enters into which kind of nerve endings? Cholinergic nerve endings. And tetanus toxin through the neurons, sensory neurons, it may go retrograde, or it may go through, you can say, circulation to the spinal cord or central nervous system. There, tetanus toxin bind with what type of neurons? Rancha cells. Is that right? Now, Rancha cells release what chemical transmitter? Glycinergic. So what we can say that botulinum toxin bind with the cholinergic nerve endings and tetanus toxin bind with glycinergic nerve ending. But once they enter into nerve ending, they have the similar function. Both of these toxins are basically proteolytic enzymes. They digest away the fusion proteins. When the fusion proteins are digested away, then in cholinergic, in patient number 1, suppose on this side where there is botulinum, and patient number 2 where there is tetanus problem, in patient number 1, cholinergic transmission fails. In patient number 2, glycinergic transmission fails. When cholinergic transmission fails at neuromuscular junction, patient develop flaccidity. And when glycinergic transmission fails in central nervous system through Rancha cell, there is no more inhibition to alpha motor neurons. So alpha motor neurons will underfire or overfire? Overfire, and that may end up into spasticity or hypertonic situation, right? Then one more condition we'll talk about. There's another condition which is called Shy-Drager syndrome. This is called Shy-Drager syndrome. Shy-Drager syndrome. Now, in this particular Shy-Drager syndrome, in the Shy-Drager syndrome, it's only 2 minutes more, there is preganglionic sympathetic neuronal loss. Preganglionic sympathetic neurons undergo degeneration. When preganglionic sympathetic neurons undergo degeneration, then sympathetic nervous system does not work very well. Patient may develop fluctuations in blood pressure, plus patient may develop problems of the sweating. Patient may develop urinary bladder atonicity, and males may develop impotence or ejaculatory problems, right? So this syndrome is called Shy-Drager syndromes. One way to remember Shy-Drager syndrome is, these are the male, we shy away from so many things. You understand their problem, their blood pressure is not stable, they sweat in an abnormal way, their urinary bladder is not stable, and their genital functions are not appropriate. Autonomic nervous system and drugs. So I will just have few words about it, especially about sympathomimetic drugs. Sympathomimetic drugs. As a class, sympathomimetic drugs are those drugs, when they are administered to a person, they produce some actions which mimic the action of sympathetic stimulation. What are sympathomimetic drugs? This is a group of drugs, when they are administered to a person, they produce biological actions which mimic the action of sympathetic activation, right? Now, when we are talking about this concept, first of all, I would like that we should develop the concept of structure and function relationship. Structure of a drug and function of a drug relationship while it's acting on a particular receptor. You know, when we are talking about these sympathomimetic drugs, it means we must know that some of them must be working on alpha-1 adrenergic receptors, right? Such drugs may work on alpha-1 adrenergic receptors, they may work on the beta-1 adrenergic receptors, and they may work on, yes, beta-2 adrenergic receptors. Right now, I'm not concentrating on alpha-2 adrenergic receptors, because when we talk about physiology and pharmacology of autonomic nervous system, that main action by the different type of ligands on the receptor is alpha 1 actions, beta 1 actions and beta 2 actions. Is that clear? Now, before I really go into detail, we'll talk about a prototype molecule which has a sympathomimetic activity. Prototype molecule which has sympathomimetic activity is, let's suppose we talk about epinephrine. Epinephrine. The basic structure of epinephrine is there is a ring structure, the phenyl ring. What is this? It's a phenyl ring. And here are two carbon. Of course, the first carbon is which one? Alpha or beta? Here it is alpha carbon and this is beta carbon. And here it is amino group. Now, this is the parent compound for most. It is not epinephrine because we have to methylate, then it will become epinephrine. What is this drug? Yes, first of all, biochemically this drug is phenyl ring with ethyl group and amino group. It's so simple. What it is? It is, yes, phenyl ring, with that there is ethyl group, with that there is amino group. So we can call it phenyl ethyl amine. Phenyl ethyl amine compound. Actually, most of the sympathomimetic drugs are derivative of this structure. They are, what is their structure? They are phenyl ethyl amine. Now, out this phenyl ring, if it gets hydroxylated, this is simple phenyl ring. If you add hydroxyl at carbon number, suppose this is 1, 2, 3, 4, 5 and 6. If you add hydroxyl group at carbon number 3 and carbon number 4, now this becomes 3,4 dihydroxyphenyl group. Now this ring will become 3,4 double hydroxylated, which group? Phenyl group. And such ring, which is phenyl ring, and it has double hydroxylations at position number 3 and 4, it means this is structurally what now after this modification? 2,3 dihydroxyphenyl ring. Now this structure is called, what is the name of this structure? This ring is called, yes please. You never heard of this ring. I am going into too much detail. You will see it is very essential to understand pharmacology of autonomic nervous system. This is called catechol ring. Have you heard of catecholamines? This is called catechol ring. So what is catechol ring? At least good students should know what is catechol ring. Catechol ring is just 3,4 dihydroxyphenyl ring. Now what is it now structure? This is catechol ethyl amine. If these hydroxylations are not there, it is simply phenyl ethyl amine with double hydroxylation at 3 hydroxylation and 4 hydroxylation. It converts into which structure? Yeah, catechol ethyl amine, or such structures are simply called amines with catechol rings, catecholamines. In a short, we call such structures catecholamines. So next time when we talk about catecholamines, it means we are talking about some sympathomimetic molecule which is having catechol ring, which is phenyl ring with 3,4 hydroxylation, because if it is 3,5 hydroxylation, then it will become resorcinol ring, which is present in terbutaline, but we will not talk about that right now. So what is this? Catechol ring with ethyl group and amino group. This is the basic structure. I have put hydroxylation here also. Who is going to tell me what is this drug actually, this particular drug? Yes, I think someone who is too good in medical sciences, Dr. Amir. What is this compound? Have you ever seen this amount, this drug, or heard of this drug? Have you heard of this drug like this? You have never heard of it. What about you? Have you heard of norepinephrine? This is norepinephrine. This is norepinephrine structure. That means you don't know the synthetic pathway for the tyrosine going to dopa, then to dopamine, then norepinephrine, then epinephrine. Anyway, this is a structure which is called, yes, norepinephrine. And if you add a methyl group here, yes please, remove one hydrogen and add methyl group, what is it? Epinephrine. What is it? Epinephrine. And if you make this end more heavy, let's suppose more CH3, more addition, you know what is it? Isoprenaline, isoproterenol. Is that right? Actually, dopamine convert into norepinephrine. It means if you talk about norepinephrine, dopamine, you know, dopamine is beta hydroxylated. Have you heard of this thing? When dopamine is beta hydroxylated, it converts into norepinephrine. It means that if I talk about the dopamine molecule, let's suppose this is a norepinephrine molecule, and if this hydroxylation is not there, now what is it? Dopamine. Because this is a dopamine structure, at beta hydroxylation you do it, then it will convert into norepinephrine, then you do methylation here, single methylation it becomes epinephrine, multiple methylation it will become synthetic molecule called isoprenaline. Is it clear or difficult? Right? Now, let's see the structure of this drug, and suppose norepinephrine is the structure or epinephrine is the structure, and the relationship with the receptors. I will discuss each point of this molecule and tell you how it affects the pharmacokinetics and pharmacodynamics of the sympathomimetic drugs. Yeah, what is this? Benzene ring or phenyl ring. Now it has been converted into, yes please, catechol ring. And here is beta carbon, and then there is alpha carbon, and then there is amino group. Is that right? This classical structure, of course, there is one hydroxy. If there is no hydroxylation here, it is dopamine. And if there is one hydroxylation here, what is it? Norepinephrine. What is the structure now? Norepinephrine. And if I make another structure here, now you have to tell me what it is. What is this structure now, please? Hurry up. Catechol. And we have added one more thing over here. This is epinephrine. Now you know the difference between norepinephrine and epinephrine? Is that right? And we can simply show this molecule like this. This molecule can be ring. Then these are two carbon units. And this is which part? Amino group. Right? This is suppose this molecule is presented graphically in a simple way like this. This is a major ring with two, of course, two hydroxylations, right? These are two methyl groups, ethyl chain, and then there is a amino group. If we compare this molecule with that molecule, this should be shown like this. Again, it is also catecholamine, carbon, carbon, amino, and this here amino group is heavier or it is lighter? Heavier. It has extra methyl. Is it difficult to understand? So what is this? Norepinephrine. And what is it? Epinephrine. And if I make one more structure here, what is this? Isoprenaline. What is it? Isoprenaline. And if I do some more modifications, and this become like this, now it is no more 3,4 is 3,5, and 2 carbon and amino group, and I've made this end very, very heavy. What could be that drug? You have heard of this drug, please? Yes, please. Someone very intelligent. Someone super intelligent. You see, what has happened? We have made this end very heavy. Salbutamol, terbutaline, albuterol, they are simply drugs with heavier amino ends. Now, let's see how this description fits into functional aspect. Let me make few cells here. This is one tissue which is loaded with alpha receptor. This is another tissue, suppose, which is loaded with beta 1 receptor, and this is still one more tissue which is loaded with beta 2 receptor. Let's suppose this is smooth muscle. It is loaded with which receptor? Alpha 1 receptor, suppose. If it is loaded with alpha 1 receptor, let me show you how the alpha 1 receptor is there. This is the basic structure of alpha 1 receptor. You know, alpha 1 receptor has one point to which the drug bind. This point of the drug is called drug binding domain or ligand binding domain or hormone binding domain. Then of course you know that it has 7 points, and this is coupled with G protein. Now, actually this drug has to fit over here. You have to be very careful. Suppose we put ideally, what is this drug? Epinephrine here. This is the ring of primary ring, phenyl ring. What is this? Hydroxyls. What are this? Ethyl group, carbon. And what are this? Amino group with methyl. Now look here, attention please. Actually, this is sympathomimetic molecule present over here. This sympathomimetic molecule which I have drawn over here, this is basically which molecule? Epinephrine. Is that right? Epinephrine. Now what really happens, that these two hydroxyls, hydroxyl number 3 and 4, they help the drug to bind with the receptor. If these two hydroxyls are removed, drug will not, it will come and touch the receptor and bounce back. So these are the ears of the drug from where we hold the drug with the receptors. Now, third hydroxylation and fourth hydroxylation in catecholamine is very important, because primarily this primary ring of the catecholamine bind with this primary depression. But actually these are third and fourth hydroxylations which hold the drug in with the receptor. Now this piece of information is very important. It means all those sympathomimetic drugs, listen carefully, which are having 3 and 4 hydroxylation, they will bind here loosely or tightly. And all those drugs which are having less hydroxylations, they will bind loosely. And if there is no hydroxylation here, they won't bind with the receptor properly. Is that right? It means that potency of a drug is determined by hydroxylation and point number 3 and 4. If drug number A has double hydroxylation, it is more potent. If drug number B has only one hydroxylation, it is less potent, less power to stimulate the receptor. And if drug number C has lost both of these hydroxylations, it won't have a capability to stimulate it. Can you tell me a drug which do not have these two hydroxylations? Yes, Maliha? Can you tell me a single drug in which these two hydroxylations are not there, so those drugs cannot directly stimulate this receptor? Tell me amphetamines, tell me ephedrine. Amphetamine and ephedrine do not have hydroxylations here, so they cannot bind with the receptors. So when you take ephedrine or amphetamine, they cannot directly stimulate sympathetic receptors. Amphetamines and ephedrine enter into nerve endings. From there they lead to the release of endogenous norepinephrine. So they cannot directly stimulate the receptor, they enter into nerve ending, and from there they release endogenous norepinephrine, and this endogenously released norepinephrine stimulates the receptor. It is indirect sympathomimetic action. So it means we can divide sympathomimetic drugs into two classes. Sympathomimetic drugs will directly stimulate the receptor, and second class of the sympathomimetic drug which cannot directly stimulate the receptor, but still they produce some activity in the body like sympathomimetic system, because those drugs enter into nerve ending and enter into vesicle and release the endogenous norepinephrine. The second group of drug is not directly stimulating the receptors, so this is called indirect sympathomimetic drugs. We can put the statement like this, listen carefully, that any sympathomimetic drug which has 3 and 4 hydroxylation will be direct sympathomimetic drugs, and any sympathomimetic drug which does not have 3-4 hydroxylation will be indirectly acting sympathomimetic drug. Is it difficult to understand or easy? Difficult? It's easy, isn't it? Another funny thing now. If I say there is drug A and which is having these double hydroxylation, it means it is catecholamine. And I have a drug B which is not having hydroxylations, these two, it means that is non-catecholamine. It means sympathomimetic drugs may be catecholamine and there may be non-catecholamine. Is that right? Catecholamines are double hydroxylated, 3,4 hydroxylated. Non-catecholamines are not 3,4 hydroxylated. Catecholamines will work directly, direct sympathomimetic action, and non-catecholamine will be indirect sympathomimetic action. Now another thing from this simple information, catecholamines are more charged because hydroxyl group add the polarity to the drug. So catecholamines are more polar and non-catecholamines are less polar. Now look, from here deduce certain things. If catecholamines are more polar, catecholamine like epinephrine, norepinephrine and dopamine. Catecholamines are more polar and non-catecholamine like amphetamine and ephedrine are less polar. The drugs which are more polar, can you take them orally? Can they dissolve from the GIT? So, epinephrine, norepinephrine, dopamine, do you hear the tablets of these things? Never. Because these drugs are highly polar compounds, they don't absorb well from the GIT. Number one. Opposite to that, amphetamine tablets are there. Ephedrine oral preparations are there. Why? Because they are not hydroxylated and 3 and 4. So, naturally, they are more lipid soluble. If they are more lipid soluble, it means they can be taken orally. So, just by concentrating on this point of the molecule, we have deduced so many things. That you remove these two, it becomes non-catecholamine. If you keep these two, it becomes, yes, catecholamine. If it is catecholamine, it is direct acting, sympathomimetic. If it is non-catecholamine, it is indirect acting. If it is catecholamine, it is more polar. If it is non-catecholamine, it is less polar. And if it is catecholamine, it is more polar, it cannot cross the biological membranes. So it cannot cross the GIT mucosa to go into blood in significant amount, and once it is in the blood, somehow it cannot cross the blood-brain barrier. Are you understanding? It means catecholamines have to be given parenterally. If you have to use dopamine, you cannot give the tablet of dopamine or syrup of dopamine. You have to use it infusion of dopamine. Have you heard of these things? So what is there? That catecholamines, when you need to give really, is there's a proper indication, you have to give these drugs orally or parenterally? Parenterally. But non-catecholamines can be given orally, number one. Another interesting thing, if I say I want sympathomimetic drug which should act on the central nervous system, it means drug should be able to cross another biological membrane. What is that? Yes? Blood-brain barrier. And if drug is going to cross blood-brain barrier, should it be catecholamine or non-catecholamine? Yeah, that is why we say amphetamine act on central nervous system, ephedrine act on the central nervous system. But if you inject adrenaline or noradrenaline or dopamine, because it does not cross blood-brain barrier significantly, it cannot produce its sympathomimetic action in the central nervous system directly. That is why when you take amphetamine and ephedrine, they have desired action in the central nervous system as well as side effect in the central nervous system. But catecholamines do not have significant side effect in the central nervous system because they do not cross blood-brain barrier. Is that right? Another interesting thing, when this drug enters into your body, there is an enzyme which will love to hold. Yeah, there is an enzyme, and this enzyme will hold this drug from these 2 points. What is the name of this enzyme? This enzyme will hold this drug from which point? These hydroxylation points. And then it will remove their hydroxyls. And rather may add the, now listen. There is another drug, there is a molecule enzyme in your body, and catecholamines come. This will remove the hydroxyl or maybe add the methyl. We call this enzyme catechol-O-methyl transferase. Catechol-O-methyl transferase. What is this enzyme? It will hold the catechols here from these ears, right? And add, transfer what? Methyl group. So that it should become more lipid soluble. Is that clear? Am I clear? Now imagine. It means if you take catecholamines, catecholamines will be attacked by which enzyme? COMT, catecholomethyltransferases. Listen, if someone has ear, you can hold him with the ear and cut his ear. But if someone does not have ear, can you catch him with the ear? Okay, now this another deduction can come. We talk about the drugs like amphetamine and ephedrine, which are, or pseudoephedrine, which are non-catecholamine. It means such drug do not have, yes, hydroxyl group at 3 and 4 position. If they do not have hydroxyl group at 3 and 4 position, it means that COMT cannot attack them, because this is an enzyme which attacks in the ears of the molecule, which is 3rd 4 hydroxylations. So this enzyme attacks very well on catecholamines but fail to work on non-catecholamine. So it means catecholamines will be rapidly catabolized and non-catecholamine will be slowly metabolized. It means duration of action of catecholamine is short and duration of action of non-catecholamine is long. That is why when you give dopamine, you have to give continuous infusion because it is rapidly destroyed. You keep on giving until you want the action. Or when you give epinephrine and norepinephrine injection, again it is for short duration. It is their actions are only for minutes. Catecholamine have their duration of action measured in minutes. But when you give non-catecholamines, amphetamines, and ephedrine, and pseudoephedrine, and related compounds, they do not have catechol ring. So COMT cannot attack them. So what will happen? The duration of action will be measured in hours. Duration of action will be measured in hours. So we have just concentrated on one point of the drug. 3,4 hydroxylation, listen carefully. If these hydroxylations are present, it is catecholamine. If these are not present, it is non-catecholamine. Catecholamines are your epinephrine, norepinephrine and dopamine. Non-catecholamines are classically amphetamine and ephedrine. Catecholamines are more polar. Non-catecholamines are less polar. Catecholamines are cannot be given orally. Non-catecholamines can be given orally. Catecholamine should be given parenterally. They may be given orally or parenterally. Then catecholamine cannot cross blood-brain barrier. Non-catecholamine can cross blood-brain barrier. Catecholamine can work direct action because they can be held with the receptor tightly. Non-catecholamines are indirect actor. Catecholamines are more potent drug with little dose, high action because they directly bind with the receptor. Non-catecholamines are milder drugs. Catecholamines, they are caught by the enzymes, short duration of action. Non-catecholamines, long duration of action. One more concept. As I told you, the primary binding of the sympathomimetic drug with the receptor depends on this ring. But will the ring remain bound over there or not, and will it bind here weakly or strongly? It really depends on 3 and 4th hydroxylations. It means that 3 and 4th hydroxylation determine that what will be the potency of the drug. Then another thing which is very important, that intrinsic activity is determined by this point of the receptor. That receptor should be occupied by ethyl group. And what about the amino group? Actually, amino group of a drug, this particular point determines that this drug will act more on alpha 1 receptor, or it will act more on alpha 2 receptors, or beta 1 receptors, or beta 2 receptors. This is a very basic fundamental rule. Let's compare. This is one receptor, right? Now compare, this was alpha 1 receptor. What is this receptor? Alpha 1 adrenergic receptor. Now we make beta 1 receptor, and you have to note where is the difference. How the alpha 1 and beta 1 are different. These points are same, this point are same. The difference is in this amino binding region. That this region is receptor is altered. It means that a drug which has to bind to the beta 1 area, that has to have a heavier what? Amino group. It's so simple. And if I make a receptor which is beta 2 receptors, Now this is the primary difference. This is your alpha 1 receptor, alpha 1 adrenergic receptor. This is beta 1 adrenergic receptor, and this is your beta 2 adrenergic receptor. If you compare these points of the receptor, you will see that a drug which has relatively lighter alpha amino group will have more tendency to bind with alpha 1 and beta 1, and drug which is having a very heavy amino group, right, that has a more tendency to bind with beta 1 and beta 2 and less tendency to bind with alpha 1. Now look here, I told you that ideal drug in whole this game is epinephrine. It's a very balanced drug, and epinephrine bind with all three receptors. The ideal drug which can bind with all the receptors, adrenergic receptors, is epinephrine. When we talk about epinephrine, okay, let's compare now norepinephrine, epinephrine, isoprenaline and isoproterenol, isoprenaline and terbutaline. Look, you have to tell me what is this drug. What is this group now? Catechol. What is this? Norepinephrine. If hydroxylation is not there, what is that? Then it is dopamine. This is first group, first drug. Now we come to the second drug. In the second drug, you have to tell me again rapidly, what is this group? What is this ring? Benzene. And what is this now? Catechol. And what is this ethyl group with beta hydroxylation? And there is amino group, but this amino group is now methylated. What is this drug? So this was norepinephrine and this is epinephrine. Now we'll make one more drug here, right? And this is again hydroxylated, and here it is CH, OH, CH2NH, CH, and what is this? Isoproterenol or isoprenaline. American call it isoproterenol, British people call it isoprenaline. I'll make one more drug here. Again, it is just like a ring with hydroxylations. Here is 2. What is this? And this is amino group. But here there is a very bulky, what is this? Right? It may be considered salbutamol or terbutamine or albuterol. They are having different type of these ends. So let's put it here, salbutamol. Now compare a very important thing. Look, balanced drug was epinephrine. It will bind with alpha 1 receptor as well as beta 1 receptor as well as beta 2 receptor. If we call this balanced, it means for 3 receptors it will bind in an ideal fashion. Alpha 1 activity, yes, beta 1 activity and beta 2 activity. Is that right? Now, when you compare the action of norepinephrine with it, it has relatively lighter amino group. So can it really activate beta 2 receptors? No. So it will lose the action on beta 2, but it will retain the action on alpha 1 and beta 1 and very little or insignificant beta 2. Is that right? Look here, we have made it heavier on amino end, isoprenaline. And if isoprenaline has been made heavier, then will it bind with alpha 1? No. So its alpha 1 action will be shrunken, but what will be the real action? Beta 1 and beta 2. Is that right? And when we come to salbutamol, right, alpha 1 action is lost and beta 1 is relatively less, but beta 2 is far more. So it means that when we talk about the actions of these 4 drugs, it's very easy to talk about those drugs now, extremely easy. You know all the alpha adrenergic actions in the body where the alpha 1 receptors are present. We have already discussed which are the places where the beta 1 receptors are there. We have already discussed where the beta 2 receptors are there. Now, looking at this thing, if I say there is a patient with asthma, it means he needs bronchodilator. Do you think you will give this drug? No, because we need beta 2 action for bronchodilation. Norepinephrine is not worth giving. It's not going to dilate the bronchi. What do you think? Epinephrine is a good drug? Can it dilate bronchi? It can. Yes, it will dilate the bronchi, but there is a trouble. It has unwanted beta 1 action and unwanted beta alpha 1 action. It will produce tachycardias unwantedly. For example, there is a patient who has severe asthma, and if you give him adrenaline, right, there is a trouble. Even though bronchodilator will be there, but unwanted beta 1 action will be there. Unwanted beta action means that cardiac arrhythmias will be there, tachyarrhythmias. Unwanted alpha 1 action, different vascular constrictions, right, and blood pressure may go up. It's not a very good way to treat the asthma. That you are, of course, you can dilate the bronchi, but at the cost of producing tachyarrhythmia and ischemic heart disease and hypertension. That's not a very good way. What do you think? Is it a good way? It is better than before. It is better than before, but really not good when we have those drugs as well. The reason being that isoprenaline, even though it does not have alpha 1 action, but still it has balanced action on beta 1 and beta 2. It is a very good bronchodilator, but unfortunately it is strong beta 1 stimulant on the heart. So it will produce bronchodilation along with cardiotoxicity. Is that right? Undue stimulation of the heart, because the heart has beta 1 receptors. Now we come to this drug. This is really ideal one, the best one under these circumstances. Salbutamol, terbutaline, albuterol. These drugs have very heavy substitutions on the amino groups. And usually they are not catecholamine, they are not 3,4 hydroxylation, usually they are 3,5 hydroxylation, which are called resorcinol groups. But anyway, we will not go into that. The point which I really want to highlight at this very moment is that it is a very strong beta 2 action with little beta 1 action. So when you give salbutamol, right, you do dilate the bronchi, but with relatively less cardiostimulation. But of course, when you keep on increasing the dose, then with therapeutic action, side effect will also progressively increase. Is that right? Number one. Number two, again it is not an ideal drug. Because if you give injection of salbutamol or you give orally salbutamol, it will go all over the body. It will act on all beta 2 receptors. So it will not only act on bronchodilation, beta 2 receptors on the liver will lead to release of glucose, glycogenolysis. Beta 2 action on the muscle spindles will produce tremors. So again, there are some unwanted action when you give systemically salbutamol. How we avoid the situation? We give it by inhalation. So that drug should be deposited where it is really needed. Right, so bronchodilatory action is dominantly achieved, and very little drug goes to the general circulation and producing, let's suppose, hyperglycemia or hyperkalemia or tremors or other side effects. Am I clear? If you have really learned this much, let's come to a few more points. We have already discussed that what is the difference in catecholamines and non-catecholamines. Let me tell you one more point. That let's suppose we alter the structure here in a particular drug. For example, we remove hydroxylation. What is this drug now? Dopamine. And when this drug becomes dopamine, here hydroxyl has been removed, right? Can you tell me that how the dopamine work? Should I draw here dopamine? So very easy now. These two hydroxylations are there. With that there is CH2, NH2, right? Of course, there is no hydroxylations here. Is that right? Dopamine. How you will make this diagram, this type of balance? Dopamine mainly act on which receptors? With that they act on, yeah, beta 1. With that they act on alpha 1. This is very important to know it. Let me tell you how. You know, dopaminergic receptors are present on splanchnic circulation as well as renal circulation. And when dopamine receptors on renal circulation are stimulated, they lead to renal dilation. This drug is a marvelous drug when someone comes to you who needs cardio stimulation and patient is in shock. If someone is in shock, it means renal perfusion is very less. If renal perfusion is very less, it means that patient is threatened to have acute tubular necrosis. Again, for example, a patient comes to you, you want to stimulate his heart, or at least you want to dilate his renal vessels, because the person who come to you with in shock, during the shock severe sympathetic overflow occur, and severe sympathetic overflow produces a severe constriction of renal vessels, and sometimes renal blood flow becomes so less that it may produce acute tubular necrosis due to ischemia to the kidney. So, in a patient who come to you with cardiovascular destabilization with renal constriction, and you want to protect the kidney, the guardian of renal system is, renal vasculature is dopamine. You give slow infusion of dopamine. Dopamine will stimulate the heart to maintain the blood pressure, but at the same time it will dilate the renal vessel, so that the risk of renal tubular acute tubular necrosis should be reduced. Is that clear? So this is basically how dopamine is renal protective. With that, of course, it has an added advantage of cardio stimulation, positive inotropic action, but the point which you have to remember is never give too high dose of dopamine. You know why? If you give very heavy dose of dopamine, infusion rate is very high, then dopamine start which actions? Alpha 1 action, and then renoprotective effect is lost. Again, renal vessels start constricting. Secondly, alpha 1 may lead to the high vasoconstriction, and heart may not be able to pump against the very constricted arteries. Right? Let's come to another drug which has a mainly beta 1 action with very little alpha 1 and very little beta 2. Yeah, dobutamine. This is dobutamine. So what is this drug? Dobutamine. Right? Now I make another drug here, and you have to tell me what is this drug. I'm going to make structure. Something like this. What is this drug? This is amphetamine. This is non-catecholamine. There is no ring here. When you want a non-catecholamine, a very good non-catecholamine, it means you need least polar compound with longer duration of action. How you make a very good non-catecholamine? Number one, you lose 3 and 4 hydroxylations. You already know the advantage of this, losing 3 and 4 hydroxylation. What were the advantages? Yeah. Number one, it can be orally, it cannot be direct stimulant. Number two, it can be taken orally. Number two, it will not be destroyed by COMT, so longer duration of action. Number three, it will cross the blood-brain barrier and produce CNS desired action or unwanted action. And next, that you can also remove this. You know, there was a hydroxyl over here in the primary compounds. You get it? Now, usually there is a cat over here. Which is sitting over here. This is monoamine oxidase enzyme. Monoamine oxidase enzyme bind at this point, and then it attacks on this hydroxyl. Sometimes we can become naughty with the enzymes. You know what we do? We make synthetic compounds. In that compound, we do a game over here that, look, first of all, to prolong the duration of action, you have removed the hydroxyls. Is that right? Non-catecholamine. Number two, if there is hydroxyl here, it is vulnerable to which attack? Monoamine oxidase. You do a game over here. You put here a methyl group. And then there is NH. Do you think methyl group is highly lipid soluble group? Do you think your monoamine oxidase can sit over here now? No, because this was the point where monoamine oxidase could sit, and you have altered this point. When the enzyme cannot sit over here, can it destroy the molecule? No. So by simple addition of this methylation, we have achieved two benefits. One benefit, we have made the drug resistant to the action of monoamine oxidase. So duration of action is further prolonged. That already, because these 2 points were altered, COMT could not work, catecholomethyl transferase could not work. And when you have altered this point, then what really happens? Monoamine oxidase cannot work as well. So it means duration of this drug will be longer. Secondly, by adding here methyl group, you have made it more lipid soluble. And when it becomes more lipid soluble, it means more easily crossing the biological barriers. And if you really want more faster action and more longer action, remove this thing. Remove the hydroxyls from here, remove the hydroxyls from here, add methyl group over here, and add methyl group over here. Now this is non-catecholamine, which has a very long duration of action. Is that clear? Now, let me repeat all this game. We were talking about sympathomimetic drugs and structure-function relationship. We were saying that most of the sympathomimetic drugs, they are phenyl ethyl amines. But if phenyl group has 3 and 4 hydroxylations, then we call it catechol ring. If phenyl group or benzene group has 3-4 hydroxylations, we call it catechol ring. And if catechol ring has along with that ethylamine, the group should be called catecholamines. Catecholamines, the endogenous catecholamines which are normally produced in human body, number one is dopamine. And when dopamine is beta hydroxylated, it converts into norepinephrine. And when it is methyl transferase enzyme adds the methyl on the amino group, then it converts into epinephrine. Is that right? Now you know dopamine, norepinephrine and epinephrine. And if in epinephrine, in the end of that you add more methyl group, it becomes isoprenaline. And if you add really very big bulky group, then it becomes salbutamol, terbutaline, ritrotin, those types of drugs. Now, structure function relationship. If 3-4 hydroxylations are there, it is less polar or more polar? It is more polar. It should be taken parenterally or orally? Parenterally. It's shorter duration of action, longer duration of action. Shorter duration of action. Can it cross biological membranes or not? It cannot. Is that right? So this is one thing. But if you remove the end, it is direct acting or non-indirect acting? Direct acting. And when you remove the 2 hydroxyls, now you convert the catechol into non-catecholamines. And if you end up with a drug which is non-catecholamines as amphetamines or ephedrine or pseudoephedrine, non-catecholamines, they are direct acting or indirect acting? Indirect acting, number one. Number two, can you tell me that such drugs are shorter duration of action, longer duration of action? And they are orally taken or parenterally taken? Orally better taken. Can they cross the blood-brain barrier or not? They can. Is that right? And if you want to make them more lipid soluble, remove another hydroxyl from the beta carbon. And if you want to make it more lipid soluble, add methyl. And addition of methyl will not only make it more lipid soluble, it will also make one advantage, the drug will become resistant to monoamine oxidases as well. Is that right? Am I clear? Again, when we talk about dopamine, dopamine has beta 1 stimulation. Dobutamine has also beta 1 stimulation. The difference is that dopamine has is rhinoprotective action. So someone has only cardiac problem, heart is under negative inotropic action or it's poorly contracting, but kidneys are well, you will go for which drug? Dobutamine. But if someone has a big trouble and you want to support the heart, you need positive inotropic support. With Raynaud dilatation, you will go for dopamine. Again, let me repeat it. If you want to give your patient positive inotropic support, but renal ischemia is not a problem, drug of choice is dobutamine. And if renal ischemia is also imminent, you will go for what? Dopamine. Then another thing, if you want to give some patient, listen carefully, some CNS stimulant, mild CNS stimulant, you will give catecholamines, non-catecholamines? Non-catecholamines. Is that right? If you want to give a bronchodilator, you will go for which drug? Beta 2 selective, which are salbutamol, terbutaline. Is that right? And if you want to give a patient drug which is strong arterioconstrictor, norepinephrine. So we can say norepinephrine strong arterioconstriction with cardiostimulation. Is that right? It has arterioconstriction, cardiostimulation, bronchodilation, yes please, hyperglycemia, hyperkalemia, beta 2, and tremors. This is cardiostimulation, bronchodilation, tremors, hyperglycemia, hyperkalemia. This is mainly bronchodilation with hyperglycemia, hyperkalemia, but little cardiostimulation. Is that right? If you really have few more minutes, I can explain how all these drugs alter your cardiovascular profiles. If you are interested. Anyone who is not interested, raise your hand. Anyone who is not interested, that how all these drugs affect cardiovascular profile. When I mean that how these drugs affect the cardiovascular profile, I really mean how they affect the total peripheral resistance, how do they affect the diastolic blood pressure, how do they affect the systolic blood pressure, how do they affect the pulse pressure, how do they affect the cardiac heart rate. Who is really good at these things? You are good at that. You don't want to say anything about that. Okay, let's discuss those things. I will just make a basic concept and then we will go ahead. Now we shall be talking about that how epinephrine, norepinephrine, isoprenaline, and at least first we should see how these three drugs, when given parenterally, how do they alter the cardiovascular profile of a patient. First I'll talk about a person who has not been given drug. Right? And along this parameter I will draw the different. Let's suppose this is total peripheral resistance. Total peripheral resistance. Total peripheral resistance determines the diastolic blood pressure. It determines diastolic blood pressure. Let's suppose the blood pressure of this person is 120/80 millimeter of mercury. And here it is systolic blood pressure 120. And heart rate is, let's suppose here, and this is 80 per minute. Is that right? Now this is a profile of a normal person. Total peripheral resistance is normal, diastolic is normal, systolic is normal, and heart rate is normal. Is that right? Now we inject drug. Let's suppose you inject norepinephrine. You give injection of norepinephrine first of all. Norepinephrine is, if you go to the profile of norepinephrine, it's alpha 1 stimulant and beta 1 stimulant with very little beta 2 action. So due to alpha 1 stimulant, most of the peripheral arteries will be constricted. So total peripheral resistance will go up. Total peripheral resistance will go up for a short duration. When total peripheral resistance will go up, what will happen to diastolic blood pressure? It will also go up. Right? What will happen to the heart rate? It depends on the dose. Actually, due to its beta 1 stimulation, it will like to increase the heart rate. But alpha 1 stimulation, when vessels will constrict, there is reflex bradycardia. Right? So, but direct action is more than the reflex action. So heart rate will increase to some extent. So when heart rate will increase, cardiac output will increase. You know, systolic blood pressure depends on cardiac output. So this will also increase. So what will be the real result? In this patient, we can say when total peripheral resistance due to alpha 1 action will increase, diastolic blood pressure will increase. When in this patient, due to beta 1 action, heart rate will increase and cardiac output will increase, contractility in cardiac output, right? That may lead to increase systolic blood pressure. So in this case, mean arterial blood pressure will go up. So it is hypotensive drug or hypertensive drug? It is vasopressor drug. What is it? It is vasopressor drug. Am I clear? But one thing which you have to remember is, if you increase the dose of norepinephrine, then a time will come, then reflex inhibition becomes so strong that heart rate start coming down. Anyway, after some time, we give the patient another drug. Now we are going to the second drug and we'll see how it really works. In this case, now the drug which we are going to give is epinephrine, and epinephrine has which actions? 3 actions. Alpha 1, yes, beta 1 and beta 2. Is that right? Now, what really happens, this is very important about total peripheral resistance. There are some blood vessels that have alpha 1 receptors and other blood vessels that have beta 2 receptors. When you give epinephrine, alpha 1 loaded, receptor loaded vessels will constrict, and like renal vessel will constrict, cutaneous vessels will constrict, and splanchnic vessels will constrict, GIT vessels will constrict. But skeletal muscle blood vessels which are loaded with, yeah, they are loaded with beta 2 receptors, those vessels will dilate. Am I clear? It means that when you are giving epinephrine infusion, of course, some vessels will constrict and other vessels will dilate. Now remember one thing, beta 2 receptors are more sensitive to epinephrine than alpha 1. Write it down. Beta 2 receptors are more sensitive to epinephrine than alpha 1. So if you are giving extremely low doses, of which one? Epinephrine. First action will be starting beta 2 vasodilatory action or alpha 1 vasoconstrictor action? Of course beta 2. So if you give extremely low doses, then what really happens is that there is total peripheral resistance goes down. This is dominantly which action? Beta 2 action. If you increase the concentration of the drug in the infusion or increase the rate of infusion, alpha 1 action also start. So beta 2 vasodilatory action and alpha 1 vasoconstrictor action. So some beds have reduced peripheral resistance, other vascular beds have increased vascular resistance. So total peripheral resistance will remain the same. This is alpha 1 plus beta 2 action. But if you further increase the rate of infusion, then beta 2 action cannot be enhanced, but alpha 1 action become very much amplified. Then what will happen? Blood pressure will go, total peripheral resistance will go up, dominantly alpha 1 action. This concept is extremely important to understand, only for good doctors. That when you give epinephrine, if you are giving at a very low concentration, dominant action will be beta 2 mediated vasodilatation. Is that right? If you moderate the concentration, then TPR does not change, total peripheral resistance, because beta 2 mediated vasodilatation and alpha 1 mediated vasoconstriction cancel the effects of each other. And then when you give high dose of what drug? Epinephrine, vasopressor action become. So we can say at low doses vasodepressor, at high doses it's vasopressor, and then alpha 1 action dominates. Now, what will be the action on diastolic blood pressure? Of course, you can say it that if it is low dose, diastolic will fall, because diastolic blood pressure depend on total peripheral resistance. And if this is moderate dose, diastolic blood pressure will not be affected. Is that right? And if it is high dose, then diastolic blood pressure will go up. Is that right? Now we come to GS, cardiac heart rate and cardiac output. Now, what really happens? And you are giving relatively less doses, there is peripheral vasoconstriction, dilatation, and reflex tachycardia. Vasodilatation produces reflex tachycardia. With that, it has direct beta 1 action on the heart also, again tachycardia. Or even in moderate dose, there is no reflex activity, but there is direct tachycardia. So usually, these patient goes for tachycardia. When they go for tachycardia, with that positive inotropic action due to beta 1 action, so cardiac output will go up. So when cardiac output will go up, then it means in these patients, what really happens, that diastolic may go down or may remain stable or may go up, but systolic definitely goes up. Under all these circumstances, what we can say that pulse pressure, the difference between systolic and diastolic, pulse pressure here is, okay, now you have to compare it. In norepinephrine, pulse pressure was reduced. Normal pulse pressure was the difference of 120 to 80 in 40 millimeter. Here it was 130 by 100, so 30. Here what really happens, even if it is moderate dose, it will become let's suppose 140 by, let's suppose even if it remain 80, it means pulse pressure will increase. So actually what really happens to pulse pressure, it depends on what is the concentration of epinephrine infused, right? If epinephrine is infused in low doses, pulse pressure will rise too much. In moderate doses, pulse pressure will be moderately increased. In high doses, pulse pressure will be less increased. Am I clear? Then we come to next drug. The next drug which we are going to now try, the patient has been stabilized, effect of the previous drug has been lost. Okay, you have to tell me what is this drug. The drug is mainly beta 1, beta 2 action. What is this drug, please? Yeah, isoprenaline or isoproterenol. What really happens in isoprenaline? There is no alpha 1 mediated vasoconstriction, but there is a strong beta 2 mediated vasodilation. So total peripheral resistance will down. Total peripheral resistance will go down. Isoprenaline. It is isoproterenol. Isoproterenol. The drug before that was epinephrine. And what was the drug here? Norepinephrine. Now, when you give isoproterenol, total peripheral resistance will fall. So what will happen to your diastolic blood pressure? That will also fall. Diastolic blood pressure will also fall. Is that right? Number one. Next, what happens to heart rate? Due to, listen, due to vasodilatation, there is reflex tachycardia, and due to beta 1 stimulation, there is direct tachycardia. So there is very high tachycardia for the duration of action. Now, there is very high tachycardia. Now, if you come to the cardiac output, which determines the systolic blood pressure, there is strong tachycardia with strong inotropic action due to beta 1. So systolic blood pressure should go up. Now in this particular patient, what you really see, that when you give isoprenaline or isoproterenol, for the duration of action of isoprenaline, blood vessels will dilate, there will be severe tachycardia. What will fall down? Diastolic blood pressure, which depends on total peripheral resistance, will fall down. Systolic blood pressure, which depends on cardiac output, goes up. And there is very much increase in what? Pulse pressure. For example, blood pressure here become 160 by 60. 100 millimeter of pulse pressure is there. Is that right?